Good morning and welcome to the Healthcare Affordability meeting. I will call the meeting, have the meeting come to order, and we'll note that the meeting is being recorded. If I can ask for the roll to be called, please.
Good morning, Dr. Sandra Hernandez.
Good morning. Here.
Secretary Kim Johnson.
Here.
Richard Kronick. Ian Lewis.
Present.
Elizabeth Mitchell. Here. Dr. Richard Pan.
Present.
Don Moles. 5 present, 2 absent.
Okay, and the quorum is present. Thank you. Director Landsberg, I will turn it over to you for the executive updates.
Thank you very much, Madam Secretary. Good morning, everyone. Welcome to the meeting. I'm going to start by talking about our agenda for today's meeting. So following our executive updates, we will have an action item to appoint one new advisory committee member due to a recent vacancy. However, we will take this item out of order, and first we're looking forward to hearing a cost-reducing strategy presentation from guests from Los Angeles General Medical Center's Safer at Home program. So very much looking forward to that. Following the cost-reducing strategy presentation and advisory committee vote, we'll discuss the hospital sector target adjustment methodology, considering resubmission of hospital data. Then we'll have an update on total healthcare expenditure data submission regulations, our DSG 3.0, followed by an exploration of drivers of healthcare spending across commercial payers. And last but not least, we'll have a follow-up discussion about performance improvement plans. If you did not see our email blast, we will not be holding our February 25th board meeting, so that meeting's been canceled, but we'll pick up again March 25th. We're trying to consolidate, so a little bit longer meeting today and March 25th and not one on February, no board meeting in February. Moving on to my executive updates, I'll be pretty brief, but I did want to give an update on the Rural Health Transformation Program, which is a 5-year initiative to strengthen and modernize healthcare delivery in rural and frontier communities. So in late December, CMS, the Centers for Medicare and Medicaid Services, California notified HCI that we got what we're calling sort of a provisional award of $233.6 million for the current fiscal federal year that ends October, actually ends September 30th. While this funding won't make up for the cuts that are coming to Medicaid and other programs from H.R. 1, we're very committed in California to make these investments as meaningful as possible. The funding amount is the 3rd highest award received by any state. So Texas and Alaska received more than California. We have the 3rd amount, but if you look at it on a per capita basis, California funding was actually among the lowest. 82% of California is a rural area. We have, of course, a very large population, and proud of the work that the team did to put together California's proposal. So because our original budget was $200 million per year, which was what the instructions were for states, that each state submitted a $200 million budget. Because we got a $233 million award, we are in the process of revising our budget based on the new amount and additional detail on our proposed initiatives, and that's due to CMS by this Friday. CMS then has given itself 45 days to respond, and CMS will provide funds for subsequent fiscal years at the completion of each budget period. So we're in discussions. We had our first meeting with CMS last week. There's an unusual amount, I would say, of oversight that we're expecting with this award. They've advised us that they'll actually, even once they've approved a budget, they'll be they will have to approve every award and even sub-award. So we anticipate a lot of engagement from CMS on this award, and again, always appreciate stakeholder engagement with this. So with that, just a reminder to speak into your microphones, and pleased to be here. And with that, I will turn it over to Deputy Director Pagan.
Thank you, Director Landsberg. Let's move on to the next slide. So next, I want to describe our I'd like to start with a quarterly work plan update and highlight a few items. As the director mentioned, we will have no meeting in February. You can see that in March, we will continue discussing performance improvement plans, introduce the spending target data submission enforcement regulatory text, discuss comments on the total healthcare expenditures data submission guide 3.0 regulations, and introduce the cost and market impact review regulatory text revisions due to AB 1415. In April, we'll move to spending target penalties, provide an update on hospital spending measurement, and updates on the various reg packages we are juggling. The advisory committee will receive these updates as well. And then I want to take us to our next slide, which is future topics beyond April. So in the category of total healthcare expenditures and spending targets, we'll continue to provide updates on the data submission enforcement regulations package. We're estimating that it'll go to the Office of Administrative Law in early May. Previously, we had estimated it would go to OAL in April. We'll also continue discussions around spending target enforcement with a discussion on penalties, holding a board vote, and developing regulations. And then we'll issue our interim report on healthcare spending. This is the report that's going to be for calendar years 2023 and 2024. In the category of promoting high-value system performance, we'll discuss the behavioral health investment benchmark and results of additional HPD or healthcare payments database analysis on behavioral health spending, provide updates on the HCI primary care snapshot that we introduced to the board earlier last year, and introduce recommendations for the equity and quality adjustment. In the category for assessing market consolidation, we'll provide updates on any material change notices received, transactions, receiving waiver or warranting a cost and market impact review, and timing of reviews for notices and CMIRs. In addition, we'll provide a status update on the AB 1415 regulatory text, which is scheduled to have an August effective date. Next slide. So now I want to provide an update on our 2026 reporting roadmap. In the first column, we have THCE and spending targets program area, and this year we plan to issue the following. This quarter, we have cost driver issue brief number 1, which focuses on population aging, utilization, and chronic condition prevalence. Later in this meeting, you'll hear from Andrew Fair for more details on this item. In quarter 2, we have 4 publications. It's the OCA facility level national provider identifier crosswalk. So this is what we discussed with you all in December, where we'll have a crosswalk that maps hospital facilities to NPIs. And then we'll also release the OCA facility level inpatient and outpatient spending data set. And then, as I mentioned, the interim spending report. And then we'll also have a second cost driver issue brief focused on intensity of services. In quarter 4, we have a third cost driver issue brief, which will focus on regional price variation and shoppable services. And then moving on to the promoting high value program area, we'll issue the HCI primary care snapshot brief in quarter 1. And then we expect that brief to be actually released within the next week or 2. We'll share results from the HPD behavioral health spending analysis that will help inform any decisions on the benchmark. And in the third quarter, we have the 3 publications listed here, which is health system performance baseline report. So you're familiar with the baseline report, which focus on healthcare spending. So this will be a separate baseline report on health system performance, which will include data on quality and equity measures, workforce stability, and APMs in primary care. We'll release a static version of the HCI primary care snapshot, and then we'll provide additional information on any HPD behavioral health spending analyses. So taking us to the next slide. So I'll discuss projected AB 14, our projected timeline for AB 1415 revisions to the CMIR regulations. We discussed in November that AB 1415 had been chaptered, which amends the OCA statute. The changes effective January 1 of this year expanded the requirements for transaction notices and those who must file such notice, including private equity groups, hedge funds, and management services organizations. OCA has been engaging with stakeholders since November and is continuing to refine text for regulatory updates, which we plan on bringing to the board in March and April of this year. This will bookend a public comment period and include advisory committee feedback from the April meeting. After we receive all comments, we'll finalize the text and proceed with the formal emergency rulemaking process. As you can see from the timeline, we estimate the package going to OAL in July with an August effective date. So now I'll provide a summary of the 2024 National Health Expenditures report from CMS that was recently published in Health Affairs. In 2024, healthcare spending reached $5.3 trillion, amounting to $15,474 per person. This is a per capita growth rate of 6.1%, slightly slower than the 6.5% growth seen in the prior year, but higher than the 4% seen in 2022 and 2021. By coverage type, Medicaid experienced the sharpest increase in 2024, with per enrollee spending climbing to $11,050. This is a growth rate of 16.1%, more than double the 6.5% increase seen in 2023. According to the article, this increase for Medicaid is partly driven by shifts in enrollment composition following the rollback of continuous coverage protections, as well as rising provider payment rates. Shifting to Medicare, spending per enrollee reached $16,779 in 2024, growing 5.4%. While still an increase, this represents a slowdown from the 6.7% growth seen in 2023. Growth in private health insurance spending also slowed in 2024. Average spending per enrollee reached $7,676, an increase of 5.2%, down from 9.6% in 2023. And then private health insurers' non-medical spending, such as administrative costs, taxes, and fees, also grew at a slower pace, rising 4.4% compared to 10.5% the previous year. Next slide. The article goes on to describe the insurance rates. The insured population decreased from an all-time high of 92.5% in 2023 to 91.8% in 2024. And then in terms of drivers of cost of spending growth, similar to last year, they concluded it wasn't prices, it was how much care people used and the intensity of that care. According to the authors, in 2024, medical price growth contributed about 2.5 percentage points, while non-price factors such as the use and intensity of services accounted for a larger share at 3.6 percentage points of the overall 6.1% per capita increase. In 2024, the three largest spending categories continued to account for a significant share of overall health expenditures. Hospital care represented 31% of total spending and grew 8.9%, a slower pace than the 10.6% increase in 2023. Growth was also strong for private health insurance at 10.4%, followed by Medicaid at 8.5% and Medicare at 6.9%. Prices for hospital care also rose 3.4%, the fastest growth since 2007 and up from 2.7% last year. They go on to describe the categories for physician and clinical services and the makeup in terms of shares of spending and growth rates are also described on this slide. So I'll take us to our next slide. So this is just recapping the earlier publications I mentioned earlier. We want to inform the board and the public that OCA emailed hospitals and posted a preliminary facility level crosswalk to support implementation of our hospital spending workstream. In addition, we posted the cost driver issue brief, which used HPD data to build upon findings from the baseline report. And I'll take us to our next slide, which is OCA is establishing a patient and consumer forum that will convene two to four times per year. The goals of the forum are to actively engage patients, consumers, and advisory groups in our work, advocacy groups, to listen and understand their concerns and lived experiences, to inform these groups on the work of OCA and the board. The inaugural session will be held March 10th, 2026. We'll hold this in person as well as virtually to ensure accessibility. That concludes my executive update. I just want to provide an update on the slide formatting key. So as with every meeting, yellow indicates informational items for the board and decision-making items for OCA, and green indicates current or future action items for the board. And I'll turn it back to the chair.
Thank you, Deputy Director and Director, for those updates. I also want to make sure the record reflects Dr. Kronick is here with us. Board Member Mitchell, questions from the board.
Thank you. That was a lot, so I'll try to go backwards. But first of all, I think that National Health Insurance expenditure data, which is obviously depressing, but I do think that they excluded administrative costs for the commercial sector, so admin, vendors, all of that. So I think that that is something that we should still look at, even if it is not reflected there as a primary cost driver. So just wanted to put that on the table. And then my question is, or questions are regarding the primary care work you mentioned and the rural transformation grant. How are you partnering with local initiatives that may already be doing like primary care payment reform, and there's so much good work happening in California? Like, will this intersect and will you leverage that?
Yeah, absolutely. Thanks very much for the question. So Dr. Lemon Tefera, who's our Chief Medical Officer, has been having a lot of those and other members of the HCI staff have been having a lot of those conversations. We just met Monday morning with a group that's working in Kern and Bakersfield. So absolutely, there's exciting good work happening in many rural areas. And so I think I talked last meeting about the three components of our rural health transformation program. One is this transformative care model, very much focusing on primary care and maternity care, and then connecting small clinics and small rural hospitals with bigger hospitals to do some of the specialty care through e-consult or telehealth, really trying to avoid that rural bypass and let people get care in their communities, do as much chronic disease management and primary care. So yeah, there are great collaboratives like this already, so we're trying to identify the accelerator programs to help support those, and then learn the best practices so that we can help incubate those similar sets of collaborations in other areas that may not have them.
Yeah, I really appreciate that. Having done this work on the ground in another state, like when there is if there is like a table where the work is already happening or an initiative, like just aligning with that as opposed to sort of introducing a whole new thing can often accelerate progress. So I think that's great.
Thank you. Richard.
Thank you, and I really appreciate the presentation. Actually, just a few, I guess, questions, comments about the national health expenditure data that was shared. So I appreciate the fact that they indicated that the medical price growth contribution was 2.5%, and that the rest was actually usage intensity. I would make note that in 2024, the actual consumer price index, or the inflation rate, was actually 2.9%. So that means the price growth in medical price actually is below the average, the CPI increase for that year. And also, think about the physician spend increase, the price for that category only grew 1.8% compared to, again, general inflation, and people's practices have to pay rent and they pay utilities and so forth, right? So they are affected by the overall consumer price index as well, is 1.8% again compared to 2.9 for the for the CPI. In terms of the the usage intensity, did the paper sort of discuss a bit about what's driving that? We have an aging population. We have some other things going on. Probably doesn't help that we're having return of preventable disease right now, like measles and hopefully not polio. But is there some discussion, probably not in 2024, but was there some discussion about this increased use and intensity? Because it looks like, well, I wouldn't say price isn't a problem, but it seems like that's where what's pushing the growth much more than the price, which actually is below the CPI.
The question is, did they discuss it further? Kind of what's...
Yes, I mean, as we're looking at this growth, right, and we're saying, oh, look at what the national health expenditure growth drivers are. The increase in cost, at least on average, right, was less than actually the growth of general inflation, which was 2.9% for 2024, right? So it's 2.5% here. So the rest is being driven by increased use and intensity. And so, if we're looking at growth of healthcare expenditures, at least in this national survey, understanding what's driving that growth in intensity and use is going to be, equally important, if not more important, to try to think about what the cost drivers are, because, the growth in price is below the general consumer price index growth for that year.
Yeah, I don't have a clear recollection of what they said in the article, but that's something we could follow up with you about.
Okay.
I don't know if Elizabeth, if you have anything from a purchaser perspective, kind of if the non-price factors that are impacting spending for 2024.
Well, I think the report really underestimates price. I mean, it might not be in Medicaid and Medicare, but in commercial, price is a major driver. And I do think,
well, the NHE is more than just Medicare and Medicaid, right?
Yeah.
yes,
Yeah.
but I think
yes.
it might neutralize some of it. But I also just, there are some nuances around coding intensity that they talk about that, could also suggest price, but even if it's in a different category. So I don't know if that answers your question.
Okay. Well, let's put it this way. I would prefer to have accurate data versus speculation. Then I guess the one other thing I just want to mention, which is less about your presentation, is, we get our public comment, and I realize that some in the public comment, certainly people are pushing for certain policy positions for us to take and so forth, and we'll discuss those when we approach those policies. But also when in in the letters that we've gotten, when they cite what they consider to be factual errors, it would be important, I think, for at least for me and I think the public, to either say that we acknowledge that maybe they might be right, or no, this is why they're wrong when they're claiming there's a factual error. So, because we should be making decisions based on facts, right? And so there are certain claims that were made in those letters about, whether, and I think that, at least in some way, hopefully that can be communicated to the board when we receive a public comment that says, there's, the information that was presented to you is not correct, that we have some assessment from our staff as to the accuracy or inaccuracy of that statement, right? Because otherwise, how are we supposed to judge? Someone now made a claim that there was a misunderstanding, there was a mess, what was presented was not accurate. We need to have some way to at least be able to say that, okay, well, and fine, maybe we made a mistake, or no, they were wrong, and this is why. So if we can, that, I think that would be helpful, because we do, we are getting letters that basically saying that, well, what's being presented is not an accurate reflection, right? And so I get it, we don't respond in time to a public comment, but having at least some sort of analysis would be helpful, so we know how to, I'm reading the public comment, I want to be able to, if someone asks me about, say, yes, and therefore, actually, we would disagree with that, and these are the reasons why, right, with that characterization of this being inaccurate.
Thank you, Dr. Pan. We hear the request and we'll take that back and figure out how we can best convey that.
Okay, thank you. Yeah, and it may not necessarily be a presentation at a board meeting, maybe something for the board members in writing or something like that, but you'll figure it out and let us know. Thank you.
Any other comments or questions from board members? Okay, we'll open it up to public comment on the executive updates.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period at the end of the meeting. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually may raise their hand. Those dialing in can press *5. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comment at the email address provided on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during public comment that is not included on the meeting agenda, except to place the matter on a future agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel for Health Access California. We want to start by appreciating the Patient and Consumer Forum that is scheduled now. We think we have heard from a number of organizations that having a more informal setting in which to express the views of various patient advocacy and consumer advocacy groups would be helpful. We continue to have concerns about it's always challenging in a state the size of California as opposed to a state the size of Rhode Island or Delaware to have hear all the voices we all should hear, but it is creating that opportunity is helpful, and we think it will also allow people to air things that may not yet be on the public agenda, but that would otherwise emerge on the public agenda through legislation, which we have seen many times, whether it was the long fight the autism advocates had to get autism care covered, or the discussions now about weight and the GLP-1s and many other issues we've seen emerge over the decades. So we think it's a useful forum. We're pleased that California got an award for rural health transformation, although it seems kind of modest up against the scale of California. I know it's 82% of our land mass, but it's not quite that much of our population. So it's nice that we got something, but it didn't seem like much given the work before all of us. So with respect to the national health expenditures, I would just say, looking at that and the various other reports that are covered, I am struck by how much things bounce around year to year and how 2024 is still a recovery year from the odd years of the pandemic. And so I just think that's, as we think about this, rather than focusing, I too am tempted to focus on the details of a specific year, but things do have a tendency to bounce around. And I think the volatility of all this data is something that we have become mindful of.
2 minutes.
And I want to make a note about one of the letters that you got, because this doesn't happen very often. Salinas Valley wrote to you about their concerns. Health Access sponsored AB 1415 last year, which would have allowed OCA to look at the entire hospital system. It was the opposition of the California Hospital Association, of which we presume Salinas Valley is a member in good standing, that forced us to remove those provisions in that prevents looking at this in the way that Salinas Valley suggests. We are also a little skeptical of their citations on cost shifting. We would note that one of their studies dates back to 1983, when I think Medicare and Medicaid pricing were rather different. And another one was authored by the then CEO of Cedars-Sinai, so might have had a particular perspective.
3 minutes.
We agree with Salinas Valley that lower hospital costs should result in lower premiums and lower cost sharing, and we are pleased that that's why the existing law requires DMHC to look at the OCA targets as they're engaging in rate review, and we will be pursuing that farther. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Snuck up behind you. What kind of setup was that? Okay. Mulligan. Hi. Happy New Year again. Steve McDougall, representing CFT, a union of educators and classified professionals, and I also sit on the executive board and executive committee of MCSIG, a JP in Monterey, based in Monterey County, providing healthcare benefits to public sector employees, mostly educators. 1983, I think I was trying to hide from the freshmen in the halls of Messina High School in upstate New York in 1983. So yeah, I think things have changed since then. I heard questions about facts. I just want to center the focus on the why. Here's some facts. The PPO Select Plan in MCSIG, which is our cheapest plan, for a family costs $29,172 a year, of which the employee has to contribute $9,610 towards. Our plan with the best benefits, because folks need them, they're in a position where they're not well as a family, cost this year $53,316 a year. We shouldn't talk about monthly cost of plans anymore. Let's just call it what it is, what it costs per year, of which the employees have to contribute $23,664 toward each year through payroll deduction. Those are the facts and the why. And, oh, we mistakenly submitted the wrong data. Mistakenly? We want a mulligan? It tells you the spirit of the legislation and regulation hasn't been honored, and now we want to do it differently. Meanwhile, the citizens, the consumers, are still suffering with astronomical raises, and I don't know where it goes from here. Yeah, we're going to use the federal administration as an excuse, but there would have been another one anyway. I trust that. Thank you.
Thank you. Looking virtually, seeing no hands raised, and to the podium. Seeing no one at the podium, that concludes public comment on this item.
Thank you very much. We are going to move on to item 3, our consent item. And I'll turn it back over to Deputy Director Pagani.
We have the meeting minutes. The minutes and written public comment received since our last meeting have been distributed.
Thank you. Is there a motion to approve action consent item number 3?
So moved.
Is there a second? Okay.
Second.
We'll now open it up. Any questions or comments from the board? We'll open it up for public comment.
All right, seeing no comments or questions from the board, we'll take public comment on this item. Please step to the podium or raise your hand virtually. Seeing no one at the podium and no hands raised, that concludes comment on this item.
Okay, can we call a roll call vote, please?
Dr. Sandra Hernandez,
I abstain. I wasn't at the meeting.
Secretary Kim Johnson,
Aye.
Richard Kronick,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan,
Aye.
Don, that's 5 in favor, 1 abstain.
Great, and motion approves. Those are approved. As the director referenced, we are going to move on now to item 5. We're going to come back to item 4. So at this time, I'd like to welcome Margaretta Brand, our Assistant Deputy Director, to introduce our guests for this item, cost reducing strategies.
Thank you, Secretary. Good morning, members of the board. Today, leadership from the LA General Medical Center will present on the Safer at Home program as an example of a cost-reducing strategy. And just as a reminder, the goal of OCA's cost-reducing strategy project is to highlight examples of successful cost-reducing strategies that also maintain or improve quality of care. And so OCA is working with health plans, hospitals, and physician organizations to highlight examples of cost-reducing strategies that have demonstrated results in their organizations. And also of note that OCA did not independently verify information about the strategies or the results provided by the healthcare entities, and we are not endorsing any specific healthcare entity or strategy. We have identified these as examples of strategies that can be a resource to others. And another note and reminder that we are always seeking examples, additional examples of cost-reducing strategies. And if a healthcare entity has an example they want to share with OCA, you can contact us using our general inbox if you would like to propose a cost-reducing strategy for consideration, and we will follow up to learn more. So now I'd like to invite our presenters from LA General Medical Center, and I'll do a quick introduction. So Dr. Brad Spellberg is the Chief Medical Officer at the Los Angeles General Medical Center. He developed the concept of Safer at Home with Dr. Banerjee, and Dr. Josh Banerjee is the Associate CMO of Transitions of Care at LA General, and he built the first iteration of Safer at Home during COVID, and then also hired Dr. Lynch to run the program. And Dr. Chris Lynch, who is online with us today, is the medical director of the Safer at Home program and runs its day-to-day operations, including implementing continual modifications and updates. So thank you both for being here. Thank you, Dr. Lynch, for being online, and I'll now turn it over to Dr. Spellberg.
We want to start by sincerely thanking you for the opportunity to talk with you today about a program that we're extremely passionate about. Oh, is it not on? It was green. Okay, all right, okay. I'll be closer, Dr. Pan, we met years ago. I'm an infectious disease doctor, and so we've worked together in the past. It's great to see you again, and very nice to meet all of you. So the first point to make about Safer at Home is that it is not hospital at home. It in fact, whoops, I went too far. It does not meet Medicare criteria for a hospital at home because we don't send hospital staff to the house. Medicare requires to bill for a hospital at home. You have to have 2 in-person visits for vital sign checks in the home. We are doing this entirely virtually. And monitoring patients, everyone gets a pulse ox and a thermometer, which we can remotely monitor. And then we have disease-specific allocations for other DME. If you have heart failure, you're going to get a scale. We're going to weigh you every day. We're going to adjust your diuretics based on your daily weight and other disease-specific allocations as well. There is a daily phone and video visit now with a nurse who is supervised by an attending hospitalist. None of the medications are given intravenously. If we can give home intravenous medications, we have a home health contractor. That is not this program. And we'll talk about the innovation around that and why that is the case in a minute. The history here is really important. We invented this program in what, Josh, March or April of 2020? March 2020, after we saw what happened in Italy and New York from COVID. We're the biggest public hospital west of Texas in the United States, and we knew where all the COVID patients were going to end up. So as we watched those other hospitals and those other parts of the world go under, we said, we need a virtual program. We need to figure out how are we going to get patients who have acute COVID pneumonia out of the hospital or we're going to go under. And Dr. Banerjee was able to work with various vendors and we developed protocols and we literally began. This is not like somebody with the sniffles. These were patients who came into our ER requiring oxygen from their pneumonia. They were not intubated. They were not requiring high flow. They were requiring nasal cannula oxygen. And we were able to discharge them from the emergency department without them ever going upstairs with an oxygen concentrator and tank and virtual care. Ultimately, our system cared for more than 4,000 COVID pneumonia patients over a 3-year period using this program, and not one died at home. 0. Now, there were some patients who got worse. 3 or 4% of them got worse. But the program has a built-in mechanism using UberMed to get people back to the hospital within an hour or two, so that if they were starting to get worse, we detected that and we brought them back and admitted them to the hospital. In January of 2021, 60% of our inpatients had COVID, 98% of our ICU was COVID, and we were within 18 hours of triggering triage. We actually had the triage officer in place and the protocols. Tomorrow morning, if this surge does not ease, we will begin triaging people to life or death. Thankfully, literally the next morning, it began to ease and we didn't activate. But that was despite sending 4,000 patients home. If we had not had this program, we would have been triaging to life or death much earlier in the pandemic. So as we emerge from the pandemic, our CEO, Mr. Jorge Orozco, says to us, if you can care for COVID pneumonia at home, how come you can't do other diseases at home? And we said, that's a really good question. So we began to develop protocols around other diseases. As Dr. Banerjee always mentions, the real innovation here is the change in medical practice, which has not caught on in part because payers have not supported it. One of the most common reasons to admit people to the hospital that payers love, you need IV antibiotics. Oh, they're more powerful than oral antibiotics. They are not. That is an old sort of urban legend. There are 23 published randomized controlled trials showing that oral antibiotics are as effective as IV for bone infections, blood infections, and heart valve infections. And yet we still routinely admit people to the hospital for the more powerful IV antibiotics that we don't need to do anymore. But guess what? The payers pay you to do it. So hospitals are going to keep doing it. We started treating those patients very rapidly with orals so we could get them home when they otherwise would have been in the hospital on IV. And the COVID experience taught us, look, we can deliver oxygen safely at home as well, which we never used to do. If you have pneumonia and you require oxygen, you're going in the hospital. But COVID taught us we don't necessarily have to do that anymore. So everybody knows it's bad to be in a hospital. You should only be in a hospital if you must be in a hospital. It's dangerous. Harm events occur. It's very expensive. And we're a safety net hospital. I'm going to show you our payer mix towards the end, and it's astounding what our payer mix is. Our patients can't afford to be in a hospital for a week. If they miss work for a week, they can't pay their rent, right? It's really burdensome to patients and their families to trap people and they're not able to go to work in hospital so I can give them an IV twice a day. That is not good. That is not patient-centered care. We're trying to get people home into a more therapeutic environment and get them back to work as soon as possible. Why are we not doing the standard hospital at home? Similar problem in rural hospitals. When you live in Los Angeles, it can take you an hour to go 5 miles. So we're supposed to take our nurses and send them all over the county. We don't have enough nurses to staff our existing beds. There's no way for us to send our nurses all over the county in traffic. Nurses, we see 2 or 3 patients a day. Doing this virtually, we literally have 2 FTEs of nursing and a half FTE of hospitals that cares for 25 to 35 patients per day. Much less expensive and much more efficiently than if they were in the hospital or if we were sending staff to the home. And I'll tell you something, Josh can attest to this, as can Chris, who's online. Our patients love this program. It turns out it's not fun to be in the hospital. You can't get no sleep. The bleeps and bleeping machines are waking you up. You're getting waken up at 4 in the morning to get your blood drawn. The beds aren't comfortable. People don't like the food. People are much, and also you trap them in a bed. They don't stand up for 2 days. You know this, Dr. Penn. You put a patient in bed for 2 days and they don't stand up. They can't stand up. They decondition. Now I got to send them to a SNF for rehab. They go home, they get up and they walk to the bathroom. They take care of themselves. They don't decondition in a hospital bed. So it's much better for the patient if we can do this at home. Now, the criteria it has to be safe. And so we're going to talk a little bit more about these criteria. But basically the cornerstone is this. This is not enhanced outpatient care. The first question we ask when you refer a patient is, are you going to admit this patient or is this patient already inpatient? This is to replace inpatient care. This is not to replace people like, oh, you're just doing OBS. This is not OBS. These people either are going to get admitted to hospital or they've already been admitted, and we're going to get them home quicker. The key is the high probability of treatment response with the low probability of rapid decompensation. Let's say you have a kidney infection, you come to the hospital, your blood pressure is low, you're throwing up, you feel lousy, you're very high fever. You get IV fluids, you get antibiotics, you get some Tylenol, you get an antiemetic. An hour and a half later, you're feeling better. Your blood pressure is now stable. You're on the your trajectory is favorable. You're responding to treatment. The chance that you're going to rapidly decompensate after that is very low. You've already shown an upward trajectory, and that trajectory can be measured in hours. It doesn't have to take 3 hospital days. So we need, one of the criteria is we need to see the patient is improving before, because if they're on a downward trajectory, they could rapidly decompensate. That patient is not eligible for the program. We got a question before, and I'm going to ask Dr. Lynch to comment on how did we incorporate nursing into developing these protocols in this program. Chris, do you want to talk briefly about that? Can you hear us? Well, are you muted? All right, well, maybe I'll, when Josh started to build the program, we got together with nurse managers and our CNO and put a team of nurses and physicians together to create these protocols. The cornerstone here is the nursing staff. They work under the supervision of hospitalists, but there are protocols that the nurses follow. So I don't know if you want to add any details to that, Josh.
Yeah, I mean, the protocols were all co-developed. Oh, sorry. Yeah, you got the protocols were all co-developed with our nursing leaders, and they were nurses were selected for their expertise in acute care management. And you know, as Dr. Spellberg said, the clinical reasoning is the innovation. And so, you know, rather than advanced technology, we rely on things that are actually the cornerstone of nursing practice, like you know, education with verbalized teach back. So all the protocols, you know, when patients are sent home, it's not just that they're sent home and you know, evaluated virtually. They're empowered to actually self-monitor and, you know, bring to the attention of the nurses who are going to call them anyway, but call them earlier if any of the, you know, warning signs or symptoms would emerge that requires them to, you know, be evaluated face-to-face sooner or adjust therapy virtually.
Which also partially addresses the other question we got beforehand, which is, does this place an undue burden on families? Because now the family is having to care for their loved one at home. That's not this patient population. We're not taking patients from the ICU who are deconditioned and need physical therapy. We're talking about acutely ill patients, and we're preventing them from getting deconditioned. If these patients cannot care for themselves, they're not eligible for the program. They need to be able to do their ADLs, right? It's nice to have family around to help them cook or whatever a couple times a day, but it actually eases the burden on the family because these patients get back to work faster, so they lose less income, and that's a huge concern for our patients.
Hello? Can you all hear me?
Yes.
All right. I had to switch over to my phone, so apologies for the tech challenges, but I just want to add that our nursing team has been absolutely critical in the development and maintenance of Safer at Home. So from the very beginning of the expansion, the first expansion of Safer at Home, our CNO identified a strong group of nurses to work with us, and they were instrumental in creating our phone call follow-up scripts to escalation pathways. They helped develop our patient education materials, and they've continued to be our key stakeholders. And we have bi-monthly operations meetings where they provide feedback and help us iterate the program. And they're also part of our leadership model. So at LA General, we utilize a triad leadership model that includes administrator, physician lead, and our nurse lead, which is Maxine Song. So they are absolutely, I consider them the heart of the program, really.
Thank you, Chris. I'm having trouble advancing to the next slide. Okay, so we have a number of diagnoses. You can see I'm not going to go through painfully, but I'll just point out one of them. Our neurologist watched us send all these heart failure and infection patients home, and they pointed out when we have patients who come in with a multiple sclerosis exacerbation, they come in to get a once per day IV infusion of steroids, and they just sit in the hospital bed for 24 hours in between those infusions. And he goes, what if we dose the steroids orally? And he came up with a way to give the exact equivalent steroid dose. And now we send MS exacerbations home with oral steroids. There's nobody else doing this. It's extremely innovative. Next slide. Let's see, there we go. Okay, so process is very simple. The care team has someone they think is eligible. They call the on-call attending, and they review the case based on the criteria we put on the web. And as I say, the first criteria is this person an inpatient? We're not enhancing outpatient care, we're replacing inpatient care. If the patient is accepted into the program, the patient and their family, and this is another question we got, undergo teaching. And that teaching is via Teach Back, as Dr. Banerjee mentioned. They are taught how to use the DME. They are taught how to contact us in real time to get hold of a nurse or a provider. And so they have to have a home. Patients who are unhoused are not eligible for the program. They have to be willing to agree that they will respond to the phone, and the family has to be okay. So the family is incorporated into that teaching that's done in our discharge lounge before they're discharged. As I mentioned before, if during day-to-day review, following the algorithms, if there are triggers to review, the nurse sees a trigger, says, I think this person needs an in-person evaluation, we will med Uber them at our cost back to our campus for an in-person evaluation. I'm going to move through the adoption stuff. Well, I'm happy to Q&A, but I want to give you guys lots of time to ask questions. So I'm going to move through this quickly. We have an order set that's built to make it easy for the physicians to enroll patients into the program. We have a staff-facing website that lays out the criteria so people can review before they refer patients. We began about 1.5 years, 2 years ago to give cell phones to our patients. Some of our patients do not have access to technology. We literally give them a pre-programmed cell phone. They press one button, they call the nurse. When they need to return, or they can text message the nurse with another button. When they need to return the phone at the end of the program, we give them a prepaid for package, and all they do is press a button and it prints out a FedEx label, and they FedEx the phones back to us. We get 85% of our phones back, and we are happy to eat the cost for the other 15%. This is extremely empowering for our patients. Okay, what are the results of the program? This is published in JAMA Network Open. We studied the first 12 months of the program. We had 876 patients enrolled. We carefully matched them to 1,590 control patients with the same diagnoses who were not enrolled. You didn't have to enroll people in this program. So some patients just didn't get enrolled. These patients were matched by demographics, age. Importantly, they were matched by case mix index, and they were matched by predicted or expected mortality. So there was very careful matching of these controls done. And the Safer at Home patients had 4 days less inpatient per patient than the controls. Is there another intervention you can think of that reduces hospital length of stay by 4 days when your average is 5.5 days? That is almost impossible to pull off. This is a remarkable reduction in length of stay. The cost is there is an increase of half an urgent care visit per patient. So every other patient got an urgent care visit more than the controls. I've traded 4 inpatient days for a half an urgent care visit per patient, and I will make that trade 7 days a week and twice on Sundays. There was a reduction in 30-day ED revisits, no change in hospital readmissions, and no change in mortality at 30 or 90 days. Financially, the enrollment has increased as our doctors and nurses have become more experienced with the program and comfortable with it. We started enrolling 2 patients per day. We're now up to 3.5 to 4 patients per day. So as people get more comfortable with it, you get more referrals. The analysis financially I'm going to show you was based on 2 patients per day. So you should multiply this in your head by at least 1.5 for current savings. This financial analysis was also published in JAMA Network Open in a separate manuscript. And it's a complicated table, but I'm going to walk you through it piece by piece. And the first thing I'm going to point out is our payer mix. Okay, 77% Medicaid, 7% uninsured, 85% Medicaid or uninsured. The official medical technical term for that payer mix is bonkers. The DSM-5 criteria, that is a bonkers. Most hospitals are 10% Medicaid, and when they get above 10%, they become upset because they lose too much money. This is our line of business. This is who we care for, okay? Now, that's what made this program work for us, and this is one of the core messages. You lose money with this program if you have commercially insured patients because you're not admitting them to the hospital. And it turns out payers pay hospitals a lot of money to admit people to the hospital who no longer really need to be admitted to the hospital. So we lost $4 million total, and you can see the breakdown by payer. If we were principally a commercial hospital, we would have lost $40 million, right? But what offset the $4 million of revenue loss is that we avoided $10 million of inpatient variable hospital costs. And we had to pay about $700,000 for fixed costs, 2 FTEs of nursing, a half FTE hospitalist, and the cost of the DME. When you net all that out, our first year, we saved $6 million. There we go. Because we net saved on Medicaid patients, we net saved on the uninsured, but we net lost on Medicare and commercial. So then we did modeling. To make this rollable out to other hospitals that have a different payer mix, there's got to be a payment mechanism for it, right? Hospitals are not going to do this. If you tell a hospital, I'll pay you $100,000 if you admit the patient to the hospital, and I'm not going to pay you if you don't, guess what they're going to do? They're going to admit the patient to the hospital. Our modeling suggests a reimbursement mechanism at about 55% of a Medicare DRG would break even for the payer and make the hospital money. So if you were at 40, 50% of a DRG, the payer would save money because you save all the costs of the inpatient stay, and the hospital would still want to do it because they wouldn't lose all the revenue for the inpatient. So that's the sweet spot in the modeling. With that, I'm going to stop and open the floor up to questions.
I want to go first because I have to step out, and I apologize, but I wanted to just commend you for this innovative work. And my daughter was just in the hospital over the weekend. Being home is what everyone wants. You forgot the mental health piece of that, but it is huge. So, and the fact that you can give better care in a lower intensity setting and save money, I mean, that's the win-win-win, right? So I am just very curious about the resistance you're getting from the payers. I know you have a very small commercial population, and that's where I sort of focus on, but and what would help scale this? Like, you did this because it was the right thing to do clinically, which, you know, is fantastic. How do you get broader, what are your recommendations for broader adoption in the industry who might be less bold in their innovation?
Yeah, I mean, we actually were talking with Dr. Taflero about this. I would love your advice on this. I'm going to tell you something, to be honest with you. We're a county government hospital system. We're not very good at contracts. I think we're not a private hospital. We don't. So we're going to talk more and more about how we can try to build this into our future contracts. But we need help from the payers to figure out what's the right way, because it really is true. I mean, this is not anybody acting evilly. This is people using the system in place. If you tell me the hospital's going to make $100,000 if I put a patient in the bed for 5 days, and they're going to make no money if they don't, it's behavioral economics. They're going to put a patient in the bed. Payers will save money if we could create some kind of payment mechanism on this, that it's about 40 to 50% of a Medicare DRG. And so I don't know how to get the word out about that. We'll keep talking, but this is one of the reasons I want to talk to all of you. But I'd love your advice on that.
Wait, is that on that particular? We have a couple people in the queue. Okay, so we'll go Ian, then Richard, then Rick.
I mean, first piece of advice you've already followed, which is presenting here. Thank you. This is just fascinating. I hope other payers, especially and facilities, are listening. I really especially appreciated you centering this discussion in the socio-demographic needs of the population, as well as the acknowledgement that this is, you know, not an attempt to shift the skilled work onto uncompensated care. It really speaks to the patient population you're focused on, and it's, again, a marvelous example of the kind of pioneering work that the public sector can lead the private sector in. I imagine, I mean, given that Medicaid is such a huge part of this population, maybe the cost disincentive to being inpatient is less so, but for Medicare and commercial patients, there's often a big deterrent to risking going inpatient. And I'm just wondering, especially in that context, but regardless, I imagine that part of your protocols take into consideration what, you know, safeguards for the availability, the ease with which the family can care for, you know, feeding, toilet, and other needs, especially in households where the family's working 2 jobs or might not be around. I'm just wondering if you could speak to some of those safeguards that assess what is appropriate for each family situation.
Absolutely. Chris, do you want to tackle that? And Josh, you can, because they run the program day to day, so they're the best positioned to. Go ahead, Chris.
Yes. So every case is reviewed and discussed when referred to with this on-call safer home attending, and we have both general criteria and disease-specific criteria. But one of the key parts of the general criteria is that the patient is able to participate in the program, answer the phone daily, take care of themselves. However, if they are not able to independently perform their activities of daily living or they need assistance with a caregiver, then we actually require that the caregiver be present on site to participate in the enrollment process. So during the enrollment process, we use a teach-back process or approach, how to use the DME, that the patient and caregiver knows how to take the medications and that they're fully oriented with the program and able to answer questions. But kind of the built-in safety check within that is, you know, if despite trying to teach back in several attempts to demonstrate, or for the patient to demonstrate and the caregiver to demonstrate that they're able to do the requirements of the program, then the safer home attending and referring team are notified immediately to discuss next steps, whether we need to send the patient or continue to hospitalize the patient, send them back to the ED. So that's thoroughly reviewed during the enrollment process.
Chris, I think a very important point I'd like you to elaborate on. The concern is shifting burden to a caregiver. When you use the term caregiver, that's a pre-existing caregiver. We are not expecting someone who did not previously have a caregiver at home to have those responsibilities taken on by family members, correct?
Yes, correct. Absolutely.
Thank you for this wonderful presentation, and I think it really underscores that those of us who work in delivery of healthcare, there's oftentimes a discordance between innovation and delivery and reimbursement or payment mechanisms, right? Because I think in many ways, as you described this, I mean, the loss is sort of actually loss of revenue from, well, you can say that patient, I mean, as long as you filled the hospital bed with someone else, you just haven't lost anything, right? I mean, in that sense, right? I mean, it's a lost opportunity cost. I mean, clearly that the hospital, well, let's say, depending on what the reimbursement is for doing this, it's assumed that a payer would actually reimburse that enough to cover the costs and maybe a little bit of a margin, right? So there's some fixed cost overhead. Then technically this would not be a loss other than saying, well, if this patient was in the bed, I wouldn't have another patient there. But if you had another patient there, there's no loss, correct?
If the patient was a paying patient, that is true.
Yes, right.
If they were a Medicaid or uninsured patient, you would still lose by backfilling the bed. But yes, that's true.
Yeah. So I mean, I think again, as we're thinking about different payment mechanisms, so forth, and some people would argue that if you had a you know, if it was a value-based or something, that actually what happens is that you basically you have a lower cost for taking care of the same patient right? That actually it's not a loss, right? In that case. And so I think one of the things to think about when we think about these innovations, and actually when I was chair of the Assembly Health Committee, I talked about there were a lot of innovations that showed, decreased utilization, lower spending, but they were never, but they were rarely taken to scale. And why aren't they being taken to scale, right? What are the incentives? So I do think that one of the things we need to think about is how do we change that incentive structure, and how do we work with the payers as well? Because you have this amazing program, you're demonstrating all the advantages, including cost savings, and why isn't happening. But at the same time, I appreciate the questions that also came. There are going to be a subset of patients who have these diagnoses where this wouldn't work, right? Because they don't meet your criteria, and they will need to be in the hospital. And what we can't also do is saying, oh, well, because of this diagnosis, we're just going to lower your payment rate because you can do this.
Right.
But then what happens is you're going to have patients who can't fit the criteria to do safe at home, but still have the same diagnosis. So we have to think about how the payment mechanisms actually are flexible enough, and not so that we don't actually punish families. Oh, we have an innovation that works for, let's say, 80%. I don't know, you can tell me what percentage of patients if you fall into it, but then if you're in that 10 or 20%, and we see this too often, then those families actually penalized because we designed it for the other 80%, and what happens. So I think that's something for us to think about in terms of, how do we encourage our payers and our purchasers to actually give space for the innovation without punishing the families who may not, unfortunately, because of whether it's family circumstances, others, be able to actually and have to use unfortunately, a more expensive model, right? Like inpatient stay.
That's a great point. Thank you. Yes.
Rick and then Sandra.
I add my thanks and commendation on what looks like a really strong program. A question about scale. When I did a Google search, it said that average daily census was 530 patients at LA General. I don't know if that's accurate or not, but you showed in year 3 you're at 3.5 patients per day. Mm-hmm. Do you have, assuming that the 500 is somewhere close to accurate, or kind of half of 1%, or maybe getting close to 1% of the inpatient census, do you have a sense of, is that relatively small because this is a new program and because of limitations on, how many nurses and attendants you can hire for it? Or is it relatively small because there are a relatively small fraction of patients who actually might be eligible for this, even if you had more resources?
No, I think it's a great question. The only thing is, I would say, from my perspective, I guess this is a matter of perspective, that's not that small. But so rather than using average daily census, let's talk about annual discharges. So about 30,000 discharges per year. And we're enrolling around 1,500 to 2,000 patients at this point per year. That's, we're talking about, 5% of people who don't need to be in the hospital that previously would have. And you could say, well, it's only 5%. Yeah, but for those patients, the impact's large. And this gets to Dr. Pan's point. When you're a really busy public hospital, that 5% is the difference between having an ER that looks like it does on the Pit, which I don't know how many of you have watched, versus an ER that patients are flowing through and nobody's dying of a heart attack in the waiting room because they're waiting 4 hours to get into the ER. This has really helped our patient flow. That margin, that 5% margin of bed turnover, has exceedingly helped our patient flow and patient safety. So I think you're right. The reason it's only 5% is because of the criteria. It's not a resource problem for us. I can't take a patient who is in a major trauma and put them through this program. We have patients who really do need to be in the bed. Bringing up that 5% just helps with flow so much to move people through the hospital.
Yeah, thank you. That's very helpful. Second question, what do either Medicare or commercial payers pay for this program at this point?
Zero. There is no payment.
There's no payment.
There's no payment. We do not meet Medicare criteria for a hospital at home, so we can't bill Medicare. There's no Medicaid payment for the program. We will want to, the next time we renegotiate our contracts. I don't know how often that is. Our finance people know, every 5 years or whatever. We'll want to see if we can build in some kind of a payment mechanism into the individual payer contracts. But as I say, That's not our core competency historically. We're going to try. Yeah.
Well, let me add my appreciation for the innovation here and the work that you're doing. I'm curious, sort of related to Richard's question, are there any other clinical indications that you can imagine down the road that would be eligible for this kind of program?
We're constantly thinking about stuff. I mean, I'd say every few months we add a new one. I don't know if Chris or Josh want to talk about any recent conversations for future possibilities.
Yes, actually, I just met with ophthalmology and discussion with one of our lead neurologists to expand our high-dose oral steroid approach to other neuroimmunologic indications, such as optic neuritis and other varieties such as that. So I think that's an approach that we're excited to tap more into. And also we're looking into orbital cellulitis for our ophthalmology patients as well. We're also collaborating with interventional radiology for more advanced drain management that would usually need to be done inpatient. We've even managed chest tubes as well. So there's a lot of opportunity ahead.
And the second question I had really has to do with technology and the extent to which you're using technology in any way that helps scale this program.
Yeah, we are using technology. My own personal view of technology is very much along the lines of the Toyota lean production. You shouldn't build programs around technology. If you can find useful technology that make a program work, fantastic. So remote pulse oxes, that makes this program work. That's a $20 device. That's not $100,000. Like, we're using inexpensive, simple, but very effective technologies in our DME. And the cell phone with a pre-programmed app. It's very simple. It's not terribly expensive. So we're trying to use things that are simple and not overly expensive, but really work for the specific need we have for the program.
And then the last question, I saw that on your list of clinical indications was alcohol withdrawal syndrome.
Yeah.
I'm just clinically curious about.
I literally referred one of those yesterday. I was on medicine yesterday and referred one for alcohol withdrawal. Yes.
I mean, given that alcoholism is a chronic condition, I'm curious what you've learned from that particular intervention in this protocol around the effectiveness of alcohol withdrawal being done at home.
So there's
done virtually.
This is an important question. There's two parts to that question. There's the acute withdrawal symptomatology, which is what we're really tackling. And there's the addiction medicine side. All these patients get an addiction medicine consult. We are really pushing gabapentin and naltrexone to decrease the cravings. The reality is it's not quite as effective as Suboxone is for opiates. Suboxone is freaking magical. Gabapentin, naltrexone, they do reduce recidivism, but it's not quite as dramatic. But all those patients get contacted by addiction medicine. Chris, do you want to talk about the experience you've had in managing the actual withdrawal symptomatology?
Yes. I think key to any enrollment is setting expectations with the patient on what they're signing up for. And of course, we are very understanding that, as you mentioned, this is a chronic condition and relapses do happen. But I think the benefit of Safer at Home is you have the support of a whole clinical team. And as I said earlier, our nurses are really the heart of the program that are checking up on their patients, where making sure that they're taking the medication, the gabapentin taper that we prescribe appropriately, that they're taking naltrexone. And to be honest, when we started out this protocol, I was not quite familiar, as many of us, is outpatient management with the gabapentin. And my fears have been really assuaged by how effective gabapentin really is. And we haven't had really major issues with severe withdrawal. And we've had, and I'm looking forward to looking at this a deeper dive, but we've had good outcomes with the protocol and criteria we've built out with both toxicology and addiction medicine. So I really consider Safer at Home as really a partnership with our patients. And that's kind of the magic of Safer at Home.
And then my last question, thank you. My last question is around language access. So you did mention eligibility here about non-English speakers and how this program works for them.
50% of our patients do not speak English as a primary language. All of these materials have been translated into something like 25 different languages, and we have instructional videos in those languages that they go through with the nurse in the discharge lounge with their family. All of this stuff is multilingual at this point. Absolutely.
And I'll also finally echo appreciation for the presentation and just really unpacking this conversation we continue to have around incentives related to meeting the needs of individuals, and just really appreciate it in that space. My question is actually about for the patients, particularly those maybe that had previously had experiences of being treated in the hospital and now aren't. How is that going, that conversation? Are there people, is it optional? Do they have the opportunity to say, no, or just a little bit more about how that conversation is going with patients?
100% they can say no. If they don't want to do this, it's not going to work. They have to want this. That has been a rare problem. I'll let Chris and Josh, our patients love this program. They want to be home desperately. Chris, do you want to add comment?
Yeah, we have an additional pathway that we call the other pathway if patients can meet the principles of safer at home. And sometimes we'll get calls from, ED and inpatient teams being like, this patient really, really wants to go home. They really don't want to be admitted. We think there's not a formal pathway developed yet, but maybe we can work, there could be a safe way of approaching this. And those cases are discussed thoroughly. And so, in terms of the reception, I haven't really encountered much of the issue where the patient is not really thrilled to not have to be in the hospital. And if anything, patients are asking us, how can I leave the hospital?
But they can refuse if they want. Absolutely.
Okay. Thank you so much for making the time to be here and share this with us, and just the approaches that you're taking in your innovation. Greatly appreciated. We are going to open it up for public comment on this item.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. Please limit your comments to this agenda item and to 2 minutes if possible. We will go to the individual at the podium.
Beth Capel for Health Access California. Like the board members, we very much appreciate this presentation. And we also appreciate answering the questions that I think many of us had about how the patients are evaluated, and would suggest that the things that you added verbally would strengthen your presentation in order to that recognition that a patient that needs assistance with the activities of daily living or is dependent on family members would be in this situation heavily dependent on family members who in your case must all be working people themselves or people in school. As a consumer advocacy organization, part of what we've been watching as we talk about these innovations to reduce the cost of care and improve quality is, what's the impact on caregiving? If you're basically substituting a family member for a registered nurse, that may not be a very good trade in lots of situations. It is comforting to know that you've thought through that, but in reviewing the presentation, that was not obvious to us. So that would strengthen the presentation to have those criteria and also and of the evaluation of the capacity of the family to care. We've too often, I go back to the early days of HMO reform when they were sending people home hours after mastectomies and hours after a baby was born, even though they were risking jaundice in the baby, that could then not be readmitted to the newborn nursery. So thinking through the implications of sending people home is really from a clinical perspective as well as a financial perspective, and also from the family burden is a really important thing to do. And I think that would strengthen this and strengthen the discussions as you move. And to answer the question about the 20% who can't go home, it's often that the family can't care or the patient's too complicated, and I think many people within the sound of my voice have had too much experience with family caregiving to overlook those realities. So I just think that recognition of the nursing and family impact would strengthen this presentation. Thank you.
Thank you. Looking virtually, Steve, I see your hand raised. You should be unmuted on our end. Please go ahead. Steve, we're not able to hear you on this end yet. Let's, you might need to. All right, it looks like you're still muted on your end. I apologize. We will go back to the podium and come back around to you.
Good morning. I'm Victoria Valencia with the California Hospital Association. We also want to thank OCA and Los Angeles General Medical Center for coming today and presenting this uplifting and promising new care model. The results you saw today, including shorter length of stay, fewer emergency department visits, but no increase in readmissions or mortality, are exactly the kinds of outcomes California should be leaning into and expanding as we think about both quality and affordability. Before joining CHA, I worked at a community-based hospital, kind of becoming an academic hospital in Austin, Texas. I rounded regularly with the inpatient teams there. And one of a very common situation we saw as the residents are presenting to patients and we're rounding is, oh, this patient is here, quote, just for IV antibiotics. And I think this team highlighted that today. So that was still going on when I was working there. Often for cellulitis, but other infections too. Clinically, many of these patients were really stable, seemed to be feeling good, but had to stay for days or sometimes a week or more for what really just kind of seemed like logistics, not necessarily medical necessity. These stays took up inpatient beds. This was a safety net hospital too in Austin, Texas, so flow was very important to us. Increased exposure to hospital-acquired infections and just were not a good experience for patients or their families. What today's presentation shows is that this home care model can work and can work safely and well for select patients with select diagnoses. From a policy perspective, this is exactly the kind of care redesign we should be thinking about and helping state and federal policymakers work together to make models like this available for patients who could benefit the most. Thank you.
Thank you. Looking back virtually, Steve, let's try it again. All right, it looked like you're unmuted on our end. You would unmute on yours. The mic is in the top right-hand corner. All right, we'll go ahead and move to our other virtual commenter. Jane, please go ahead.
Hi, can you hear me okay?
We can, thank you.
Fantastic. My name is Jane Thomason. I am the Assistant Director for Health and Safety for the California Nurses Association. Just wanted to respond to the presentation by expressing concern on the behalf of CNA about these kinds of programs, that shifting acute care into patients' homes can jeopardize the immediate safety and even the lives of patients by removing them from the hospital setting where immediate help and medical intervention is available if a patient's condition is fragile or deteriorates quickly. We also want to call out that shifting acute care into home settings completely undermines the central role that registered nurses play in the provision of hands-on care that is what patients need to be able to safely heal and recover. Relying on monitoring technology and self-reports from patients is in no way comparable to the skilled expert nursing care and social emotional support that RNs provide every moment of every shift in a hospital setting. And without that 24/7 RN staffing, family members often need to step in, which can create stress and can leave patients attended to by lay people. We're also acutely aware that what these kinds of programs ultimately do is shift care work onto women inside the home without pay, while taking away paid care work from a predominantly female RN workforce at the hospital. And just to conclude by saying that these kinds of programs that shift acute care to homes should at very minimum be considered in the workforce stability standard, and the negative impacts on the nursing workforce should be assessed. Thank you.
Thank you. Looking back to the podium, seeing no one at the podium, Steve, we'll give it a try. All right, sorry, Steve, we were not. Give it a try one more time. All right, I apologize. We are unable to hear you on this end. We will try and work with you to figure that out, and maybe you can comment at the general public comment period later today. Seeing no one else, that concludes public comment on this item.
Thank you again. Very much appreciate you being with us today. We're going to move back to item number 4. This is our vote to appoint advisory committee members, and welcome the Engagement and Governance Group Manager, Megan Brubaker, to introduce this item.
Thank you and good morning. If we can go to the next slide. So as you may recall, we talked about a special payer recruitment process a couple of months ago. Since then, we received 13 submissions from October 29th through November 30th, 2025. At the November board meeting, the board appointed a new advisory committee selection subcommittee consisting of Sandra Hernandez and Ian Lewis. The subcommittee met in December to discuss submissions and recommend a payer for appointment. Next slide. So this slide shows the advisory committee membership as of today, and in the top left corner we can see the recommended new member in yellow highlighted to fill a vacancy in the payers category. This recommendation is for Casey Maroney, the Senior Vice President of Underwriting and Analytics and Chief Actuary of Blue Shield of California. Next slide. So here's a draft motion from the subcommittee to approve Casey Maroney to the advisory committee in the payer category. This term would end on June 30th, 2026. And so I will now turn it over to Sandra and Ian to add anything additional for the board to consider.
For my part, just a couple of comments. There were a lot of excellent applications. It was not an easy process, although I got to say the staff made the discussion as fluid as it possibly could be, and want to appreciate the work that went into that. You know, these these appointments are individual appointments, but there's, you know, in the back of my mind, at least, there's always kind of the institutional, like who getting a good representation on the board institutionally is a consideration. And the last observation I make is that there are a number of spots coming open in a couple of months' time, and we'll be going through a process of hopefully seeing a lot of reapplications as well as new applications, and look forward to that. So turn it over to Sandra if she has anything.
Yeah, thank you, Ian. I concur with all of that. I appreciate everybody who actually either self-nominated or were nominated for the process, and I think this candidate will add significant input to the advisory committee. I agree with the process and the outreach, and continue to urge people to put their hat in the ring. So, thank you.
Okay, so we'll go ahead and turn it over to the chair for board discussion.
Just echoing appreciation for all of those who applied and are continuing to engage with us. Just very much appreciate the dedication to our overall mission of what we're doing here. I will entertain a motion for approval for this member appointment for the advisory committee. Oh, sorry.
Thank you. And first of all, I want to thank both Ian and Sandra for taking this up as someone who had to do this before. And I'm also quite pleased to hear that there's such a level of interest, right, that we had so many applications to go through. I guess the one other question, and certainly sounds like this is a very capable candidate. I know that and I realize this is just an appointment for one position to fill a vacancy, but I think in the past we've also, just want to comment about degree that this candidate contributes to the geographic and other diversities of our committee. So I did hear about you know, institutional role being an important contributor. Can you just maybe briefly comment on that?
Sure. Sorry, we did not include that. We will for this next time, definitely. I think last time we looked, it was pretty diverse across the state, and we had a pretty good makeup across racial and ethnic and LGBTQ plus that we looked at. So this person, I didn't really change the makeup too much in those, but we will review those for the next when we go through the general selection process for each year.
So I'll move the nomination, Madam Chair.
Thank you. Is there a second?
I'll second.
Okay, we will, any other discussion from the board? We'll open it up for public comment then, please.
We'll now take public comment on this agenda item. Please step to the podium or raise your hand virtually. Seeing no one at the podium, we'll give it a moment. And seeing no hands virtually, that concludes public comment on this item.
Fantastic. And can we call for a roll call vote, please?
Yes, Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell. Dr. Richard Pan.
Aye.
5 in favor, 1 absent.
Fantastic. The motion is approved, and thank you again for that. And it sounds like you also might want to share with the good of the group and the public some additional opportunities in the future.
Yes. So if we go to the next slide. So I just want to remind the board and the public that from January 5th to March 31st, 2026, OCA, we are accepting submissions of interest to serve on the advisory committee to this board. Just a reminder, the advisory committee meets 4 times a year and provides input on a range of healthcare topics of interest to the board and also to the office. So Sandra and Ian Lewis, the newly approved subcommittee, will recommend a slate later this spring, and selected members will serve from July 1st, 2026 through June 30th, 2028. Further information and a link to the application are on our website. Next slide. So again, this shows the current membership with that vacant position now filled, but also open for reappointment or other options for consideration. So that's a total of 16 out of 28 members. Next slide. And this slide here shows a visual of the advisory committee member selection timeline. From January 5th to March 31st, OCA is collecting submissions of interest. From April to May, the subcommittee is analyzing submissions and will be meeting to discuss. In June and July, we will present a recommended slate to the board. And in July or October, the new appointees will attend their first advisory committee meeting. And that is all I have.
Thank you so much, Megan. And again, just appreciation for all who are engaging with us in this capacity, for the team's work on ensuring that these opportunities are available, and for the addition that we heard about earlier today of a patient advisory. Just great, tremendous appreciation to ensure that we're interacting in that way. We are going to move on to item 5B. This is the hospital sector target adjustments methodology conversation, considerations of resubmission of data. Invite Deputy Director Pagani back and Assistant Deputy Director Howard.
Good almost afternoon. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Branch. We can go to the next slide. So I'll start by sharing some background information on the hospital annual financial disclosure reports as we dive into a discussion on the possibility of considering resubmitted hospital data. So annually, every fall, HCI publishes the hospital annual financial disclosure report, complete data set. The regulatory process allows hospitals to resubmit data for a prior year. However, when HCI publishes the complete data set each year, prior years are not modified or adjusted to reflect any modifications from prior year resubmissions. The resubmissions are made available on HCI's website via the Sierra system. So we go to the next slide. So here I'll share some background information on the high cost outlier hospital sector target adjustments. The board's April 2025 action to adjust the sector target for high-cost hospital outliers relied on the HCI complete data sets from fiscal years 2018 to 2022. The refreshed analysis that the office presented to the board in December of 2025 added the fiscal year 2023 complete data set, which was published in September of 2025. The methodology included hospitals above the 85th percentile on unit and relative prices. This relative cutoff could mean that if one hospital were to drop below the 85th percentile, another could then come into the 85th percentile. Go to the next slide. So here I'll discuss some recent resubmissions of hospital data. As noted at the close of the December 2025 meeting, a hospital indicated that it had resubmitted prior year financial data and sought the board to consider the resubmitted data. After the December 2025 meeting, the hospital reached out to OCA and indicated that it believed that were the board to consider the resubmitted data from calendar years 2019 to 2022, that it would not meet the criteria that the board had used to adjust its targets on the basis of it being a high-cost outlier within the hospital sector. OCA has also subsequently learned of at least one other hospital with an adjusted sector target that has resubmitted their hospital annual financial disclosure reports for prior years. HCI is still in the process of reviewing and validating these resubmitted data for one or more hospitals for 1 or more years. And given the pending status of these resubmitted data, OCA has not rerun the target adjustment methodology and analysis based on these resubmitted data. Go to the next slide. So here I'll share and discuss some considerations for the board's discussion. The board may wish to consider more recently submitted and revised data. I'll note that whenever data are submitted, the entity attests that the data are complete and accurate. If an entity discovers an error or makes modifications for a prior year, these changes will reflect in future years because we know that we're looking at a 5-year rolling basis, so this could be assessed on a go-forward basis. OCA could consider resubmitted data during the progressive enforcement process. Hospitals may continually resubmit prior data in an effort to fall below the 85th percentile. So continuing with considerations for the board, the office would need to determine and communicate to hospitals a date by which HCI would need to receive resubmissions to ensure a fair and consistent process. Neither OCA nor the board have previously communicated guidance to hospitals regarding the process or time frame by which the board may consider resubmitted data. To date, HCI has reviewed some facilities' resubmitted data, but other facilities' data are still pending validation. If the board considered resubmitted data that HCI has validated as of, for example, December 31st, 2025, this may be perceived as unfair to the facilities whose data are still pending validation. So as a reminder, the green arrows mean that this is an item that will eventually lead to board decision. We are looking for discussion from the board on this item. Does the board desire to modify the methodology used to adjust targets to consider resubmitted data?
One question before I turn it over to other board members, and thank you for that presentation. Give us a general sense about how long it's taking for the validation process.
I'm going to phone a friend and we'll get you a more specific answer.
So I think this has come up before. So the previous data they submitted, they're setting correction for. They also had to certify that that data was accurate at the time, correct? Yes. So when they submit the resubmitted data, do they also include some kind of justification for the reason, I guess, for the adjustment and the reason why it was not, I guess, accurate the previous time? I mean, I'm sympathetic to the fact that maybe people, may have interpreted it a little differently before, and maybe in light of, more recent policies said this is a better reflection, of our data given. But I think is there a justification? In other words, they're not just saying, oh, well, we submitted wrong data before, here's better data, right? I mean, there should be, since they certified before it was accurate, we're certifying again it's accurate, what changed? What did they find out? What's new? I mean, I think, did they point something out to explain that? I have to admit that if it's only 2 hospitals in the whole state of California, that's not a whole lot, so yeah.
So I'm going to answer both questions at this point. So one, it entirely depends the timeline to complete the validations. There's often some dialogue and discourse and back and forth with the entity, and it can depend based off of the number of years that were resubmitted or just the nature of the changes. So there's not necessarily a one-size-fits-all answer. I'm sure we could come up with a more precise answer, but I can take anywhere, I believe, from weeks to months.
I appreciate that for resubmission. How about on the initial for all?
We probably should have thought.
Okay, that's okay.
To have the hospital data. So this is right. This operates within a different program outside of OCA.
The initial timeline. I believe because they just released the complete data set in September or October of 2024 or 2025. So then they kind of backing up from there. I believe that they submit the data in the spring, but yeah.
CJ, you're going to answer this.
Right, and then the second question, again, can be entirely variable in terms of what the changes were and what sorts of explanations may or may not be provided.
Well,
so I don't think
but do they give the reason? So in other words, yes, that could be. But do they, in their resubmission, say cover letter, whatever? This is why we're submitting it, and these are the changes, and why this is justified since they had to certify before it was accurate. Why? So I mean, again, mistakes can be made, but is there justification that comes with the resubmission, or is it simply like, oh, we want to resubmit our data, right? I mean, I would think that perhaps some sort of justification for why the prior submission, which they swore to was accurate, is no longer accurate, and what they found out in the time since that submission, that why they're now resubmitting.
I'm not entirely sure.
The hospital financial reporting program does have their regulations do allow for resubmission. So yeah.
Right, but Dr. Panda, so we understand your question, Dr. Panda B. Is the hospital giving a justification as to what error was made? I don't believe so, but we need to check with our colleagues in that reporting program. So are you messaging them now? Okay. Well,
Yeah.
we'll try to find that out.
Okay. Yeah. I mean, I'm not objecting to a resubmission. In fact, there could be, but a justification would be helpful, especially as you're trying to verify. Because they already swore the previous one was, or at least they signed off that the previous one was accurate. Now they're sending a new one, and they're saying this one's accurate. At least, instead of you trying to hunt around and figure it out, they should indicate what prompted them to request a resubmission and what changed.
I do believe that through the dialogue process for validating that there is some discussion between HCI and the facility to understand what the changes were.
But in both of these circumstances where this has occurred, HCI has already validated the data. Is that correct?
There's an initial validation to the first time that they've submitted.
So they've submitted, they've identified that they believe it's accurate, and HCI has validated that data. Is that correct?
Yes, and the validation, since this is self-reported data from hospitals, it's more of a desk audit for completeness and making sure they followed the instructions, but it's not like an audit necessarily. Like we go there and then look at their books or anything like that.
Yeah, I mean, given that, and I mean, we're going on what? Close to 50 years of these submissions, and I know this is a relatively new use for these reports, but they've been fairly widely relied upon for other purposes. I am concerned about creating a dynamic where there's an incentive for gaming. I'm not saying that's what's happening here, but an incentive for that, both from a policy standpoint, also pragmatically, if the staff end up in a position of having to not just do a desk audit, but do some level of actual validation of the underlying data, seems to put the office in an untenable position, especially given the affidavits that they've signed. I am heartened that there's at least some room for consideration if there are really valid reasons that during the enforcement process that we could deal with it on an ad hoc enforcement basis as opposed to trying to validate or recalculate on a constant churning basis, potentially lots of submissions.
I wonder if there's a answer in which the answer is different for old data than for new data. To Ian's point, hospitals attested to the accuracy of the data, but it was never used for anything, and they probably didn't, in many cases, pay very much attention. And understanding that it creates a burden, but creating some timeline to say, for data, prior to the announcement that we were actually going to be using it, that we would consider resubmissions, and obviously I think we need to create a timeline for that, to your point, to treat all hospitals fairly. But then kind of moving forward, we're not expecting and not planning on and not willing to kind of redo this every year. And for data that are being filed now, hospitals should know that what they're filing is going to be used. And we're not planning on recalculating which hospitals are high-cost outliers every year based on resubmissions of data for 2024, 2025, 2026. Going forward, we expect hospitals to be, producing accurate data, but we understand that for old data, when hospitals didn't know that it was going to be used, that maybe they weren't, being as careful as they should. And as long as we have some timeline so that every hospital is treated fairly, that we're willing to reconsider the designation of high-cost hospitals on the old data. That would make some sense to me, at least. I mean, it's kind of, to Richard and Ian's point, they shouldn't have done this, but I also don't know that designating a hospital as a high-cost hospital based on what may seem pretty clearly to be wrong data is something that we ought to do.
Yeah, I think the fact that we use a period of time, 2019 to 2023, and that will be rolling year over year, really does give hospitals, they should know that it is being used in a very important policy way and public way. And then if they want to correct the data on a go-forward basis in subsequent years, they're certainly free to do that. I think the justification really does matter. Like, why? Why do you need to resubmit it? Is it simply because you're in a high-cost category now? So really understanding the justification to me matters. But I think that the methodology certainly allows them to address any errors or calculations of their data, because to be fair, this is their data. And I worry that there's a slippery slope around who comes into the next category if you allow resubmissions, and then we're in a situation where I want to review the data that I've submitted so that I'm not in that category, and I think we should be very mindful of that problem, potential problem.
Thank you. I just want to be clear, there isn't, so yes, our data team is engaging with the hospital to understand the new data. There isn't a requirement for a resubmission that they somehow submit, a justification. So I just want to temper expectations around and I don't want to put our staff in the position of having to, opine as to whether it was a valid justification or not necessarily. And absolutely, to your point, Dr. Hernandez, it is true that if if the board decides to recalculate based on resubmitted data once it's been validated, that will reshuffle the deck in terms of who then hits certain benchmarks.
Well, we also don't need to put the staff in that situation. If those hospitals want to come publicly and say why data that they certified as accurate is no longer adequate, I think we should be willing to hear that as a board.
Any hospital resubmitting will come up with some answer. You know, we classified Medicare Advantage as commercial inappropriately, and we didn't understand it at the time, and now we're looking at it more carefully. And, you know, I don't know what we're gonna say about that. You know, that's a good reason or that's not a good reason. And I guess I was probably not clear in articulating, because I'm still not completely clear about what the policy should be, but I do think this could be a kind of one-time correction, that we say, you know, hospitals can resubmit data from 2022 and before, because when they submitted the 2022 data, they didn't know it was going to be used, and you know, they should have been more careful, but people are often not careful when they're doing stuff that doesn't have, you know, doesn't seem like it's going to be used. And so we could say, yes, older data can be resubmitted as long as it's done in some time frame, so that it's fair to all hospitals. But then moving forward, we're not going to keep doing this. Moving forward, we're expecting that hospitals will pay attention, and we will be calculating the high cost outliers based on the data that they've submitted.
Yeah, it seems to me in terms of what you're asking of us is that, and you know, certainly appreciate Dr. Kronik's statement, is that it's really about how often do we go back and revisit the high cost hospital, right? Because we have a set of data and then someone says, hey, my data isn't quite right. That brings me below, and someone else gets bumped up, and then that person says, or whatever, right? Because it's percentage, right? So someone gets bumped, someone else ends up in the percentage, right? I think that there is probably some point where we basically say, look, you know, for the purposes of this, at some point we're done. We're not going back, and even if you submit the data and it's wrong, you have justification, we're not changing that for that year, right? Like there's probably some deadline where it said that we're, you know, in terms of who we fit into this category, you know, sure you do it right the first time, but and then I think there's perhaps, as you said, maybe a window of opportunity that's fixed for, you know, since we're doing some of this is based on quote old data, right? But after that, going forward, we're not making, you know, if you want to resubmit and you have that's fine, but we're not going back and changing all our, we basically have deadlines for, like, this is based on the data received at such date, which people had to say it was accurate, et cetera. And if you made a mistake, okay, well, but we're not going to keep going back and say who's the high cost hospital and have a rotating thing where this person came off, that person came on. I think that's going to be too chaotic. And so if you're really that close to the line anyway, well, I guess, and you made a mistake, well, I guess I just think that there needs to be some predictability for people too.
Ian?
Yeah, I just want to just responding, Richard, to your point, just to put a fine point on the use of this data. I don't think it's been used for, certainly for spending limits and so forth, but it is pretty widely used for other purposes. I mean, certainly HCI is better placed than I to speak to various ways it's used there, but also by policymakers and the public. This data set has been pretty heavily relied upon, so that's part of the genesis of my concern about suddenly learning that there are concerns about the data unexpectedly now, and not knowing what the ramifications might be for other state work.
And just to add to what Board Member Lewis said, hospitals are actually one of the main users of the data, so that they could benchmark and, you know, for their internal strategic planning as well as the health plans. So it is fairly widely used.
Just a minor semantic point. I'm not sure that you're asking us whether we want to modify the methodology used to adjust targets. I think what you're asking us is, do we want to modify the data input used to adjust targets? And maybe somebody might say that's part of the methodology, but
yeah, it's part of the methodology.
With additional guidance, so we got some guidance there and kind of a pulse check in terms of where the board is. Go ahead, please.
Yeah, I mean, I think you heard us. I guess what I'd suggest is some deadlines, right? That's what we really like, deadlines for for that we're gonna basically, based on data submitted by a certain time, if given the fact that, at least for right now, because we're having some old data that people didn't know, if we want to give them a grace period to quote fix whatever, but we're not going after a certain deadline.
Yeah.
We're not going back, and we're just saying this is based on our policy, this is who fits in the high cost category. And if you want to resubmit data later, that's fine, but it's not going to adjust who's on there. Like, there's a certain point in time.
Yeah. I think the question that the team is asking is, there presumably is that process is inherently baked in today in terms of the certification process, the deadlines, that clarity. I think, are you suggesting that happen for resubmission on this first time and then never again, given it's a new process? Or just to be clear, because the timeline in the certification is inherently built into what we currently do. Okay.
Yeah, so in terms of communicating a deadline, as we indicated on the slide, since, as CJ mentioned, there's a few resubmissions that are in queue or in progress and not fully validated by HCI. And then there might be others that are not, we haven't communicated a deadline, so it would be hard to do it for this year because of the time frame because of the March. OCA would need to propose changes by March, similar to the way we did a memo last year, and then the board would need to act by June. So there's kind of the fairness issue that we flagged. Like, some hospitals are not aware of a timeline for resubmitted data. So practically speaking, like this, if we want to communicate a timeline in advance, it would have to be for next year, which could change the adjusted targets for calendar year 2028.
And then also just pointing out, by that point, as we talk about this rolling average, we'd have at least 2 years of those 5 where people have known that this is how the board was going to be using their data. So at that point, it just kind of begs the question from an operational and then also the potential policy implications of what could happen. I think, as Board Member Lewis pointed out, is that really something that the board wants to traffic in, or is this something that we want to push off and say, we're going to just look at this data because a year from then, and we'll have 3 years where hospitals have known how these data were going to be used. And so just putting the full context out there.
Yeah, if it's kind of operationally feasible, it would make sense to me to have some timeline to say, if you made a mistake on your submissions prior to, I guess it's 2022 or prior to 2023, right? The 2022 data were submitted in the spring of 23, and the 23 data were submitted in the spring of 24.
Yeah, they're due the quarter after the calendar year closes, or the fiscal year.
Yeah, and so maybe it's then, there's some timeline in which you can correct data from, I guess, 2024 or before. We started doing this in 2025, so maybe early 2025, hospitals still didn't understand this is going to be used. So some timeline you can correct data from 2024 or before, and the hospitals submit new data by the timeline that you've established, then we would be willing to use those corrected data moving forward. but that for, 2025 submissions and beyond, we're using the data that gets submitted and that gets, validated in the desk audit by your colleagues. We're not going to kind of keep allowing or keep using resubmissions of those data in the future.
So I mean, based on the comments we heard from staff, I guess operationally, what are you suggesting we do that would make sense operation? So we have one hospital that's already resubmitted. We have another one that you think is going to. I'm trying to remember what you presented. So hasn't done so yet.
We know of at least one that has, but
one has,
gone through
and
the
one
validation
may, right? You're hearing, like, hasn't done it yet, right? And that you expect at least the one who submitted and maybe even the one who didn't may actually have an effect on our list of high cost hospitals, right?
Good.
Okay. So, so I guess the question is, and then of course, we're only to determine that we look back 5 years, right? If I remember our definition. So we're not like looking way back, right? So, and then of course, every year we move forward anyway, it's going to be data that's been collected since people knew what they should be doing about this, right? So I guess there's basically probably some data that, as Dr. Koenig mentioned, that for some reason, and we have already won the resubmission. So the question, I guess, is that operationally, are you going, again, I'm just, you recommend that it makes sense for us to incorporate that data into a redefinition, or you're saying like, hey, it's just too complicated, or it's not? And so I know ultimately we need to make the decision, but I guess I'm looking for some advice about how operationally this would work. And we want something that's transparent and feasible, right?
Right. So I think hearing the conversation, I think we could probably follow up at our next board meeting with some digested thinking, hearing your input, and then present some potential options or pathways around how this could work out, should the board still decide that that's something that they'd like to pursue, and we can investigate this further.
Okay. I mean, yeah, I think overall, at least, it's if that we don't want that, basically we want to create, I think, transparency and predictability for people about this, whether it's the hospitals or the public. We also, if there were some errors in the data because people didn't have to put this data to the test that we're putting it to, that has some implications that people want to send corrections, that we want to at least give some space for that, but we also don't want to turn this into an ongoing, like we're, changing thing, that at some point there needs to be some certainty, you're in, you're out, and then we move forward. So thank you.
And just in terms of resubmission for the data in previous iterations, our work here, and as it's a transparency tool. So if someone does resubmit their data from 10 years ago, that's automatically posted. Do we know that? And what's the...
Yeah, I don't know about scenarios where it goes back 10 years, but it could be for prior years. And it's not posted to the complete data set that we relied on, which is kind of a file that's posted on the Cal HHS Open Portal. But then there's another page on the HCI website called Sierra, and then those are the individual reports. So revisions do get posted there.
Okay, great.
And also just to the point about this being a new use of the data, I think resubmission of data based on mistakes has been very rare.
Okay, we appreciate the discussion there, and we will look to you all for some additional recommendations for us given the board's comments. We will open up this item for public comment.
We'll now take public comment on this item. Please step to the podium. If you're attending virtually, please raise your hand. Please limit your comments to 2 minutes if possible. Looking virtually, seeing 2 hands raised, we'll go ahead and start virtually at this time. Angus, go ahead, please.
Hello, can you hear me?
Angus, you should. Now we can. Thank you. Please go ahead.
Thank you so much. Good morning, Angus Cochran from Washington Health in Fremont here. Thank you for the opportunity to provide feedback to the Healthcare Affordability Board this morning. I think it's important that we're beginning this conversation about establishing a process for removing hospitals from the high-cost hospital list when their data demonstrate they do not meet criteria for inclusion HCI has a long established process allowing hospitals to resubmit data when submissions are found to contain errors in how revenue or spending is categorized. In the past year, a third party found errors in Washington Health's HCI data submissions, which we've been working to correct. So we've submitted corrected data to HCI. HCI has accepted much of our resubmitted data and is in the process of reviewing more recent years. Based on our analysis, trying to model the OCA methodology, we anticipate that the completion of the data resubmission will result in Washington Health no longer qualifying for inclusion in the outlier list. So, we would encourage the board to adopt a methodology for adjusting targets that considers resubmitted data. It only makes sense that the OCA methodology and analysis is based on the most accurate and up-to-date data accepted by HCI. And we understand this can't be an ongoing issue for all eternity, but we'd really respectfully ask that the submission of resubmitted HCI data be considered, the review of it be considered soon after HCI accepts that resubmission. If it's found that a hospital no longer meets the criteria for inclusion on the high cost list, we would urge OCA to adopt a policy that removes the hospital from the list as soon as possible. I just want to say we really appreciate the continued partnership with HCI and with the OCA staff who have been very collaborative and helpful. And we really thank you for your serious consideration of our request. Thank you.
Thank you. Looking to the podium. Beth Capel for Health Access California. As the staff and the board consider this for the future, a few things to keep in mind, a few facts to keep in mind. The law that enabled OCA was passed in 2022. The discussion about the law had gone on for 5 years before then, starting with AB 3087 in 2018. The law that was enacted directs OCA to use existing data sources to the maximum extent possible. And that certainly includes the hospital financial data, which was part of the reason that provision was included, because we knew that data had been in place for 50 years. The hospital financial data, contrary to some assertions, was created for the purposes of cost control and was used by state government for many decades for that purpose through the California Medical Assistance Commission and other programs of the state. It is correct that those had lapsed some years before OCA was created, but it's not a new or unknown use of the data. When we listen to this discussion about 5-year rolling time periods, and we look back to the discussion that led to the enactment of the law in 2022, parties should have known that their data could be used and relied upon. It's certainly in 2022 and perhaps as early as 2018 or 2019. So there was an opportunity to do it right. The fact that not everyone got the message, apparently, speaks to the lack of due diligence on the part of the entities which are subject to the cost targets. And so our sympathy is we respect the board's desire to be fair and to use good data, but our sympathy is somewhat limited by the realities of the process. Thank you.
Looking virtually. Jane, I see your hand raised. Go ahead.
Hi, Jane Thomason with the California Nurses Association. Just to point out that the current methodology that is used to create the high cost outlier list was already very thoroughly analyzed by both the board and the public. And CNA really encourages the board to not accept resubmitted data and to not change the methodology because that methodology has already been so thoroughly vetted. We should just proceed with what we have. Thank you.
Thank you. Looking back to the podium.
Good afternoon. I'm Victoria Valencia with the California Hospital Association. We appreciate OCA raising the issue of AFDR refilings today. It's not a hypothetical problem, and it's already affecting real hospital classifications. We have spoken with the hospitals that have refiled their data after identifying errors and faulty assumptions with their previous filings. The refiling substantially changed their measured values against OCA's high cost target definition and criteria, showing at least one hospital would no longer meet OCA's criteria for high cost hospitals when the measurement window moves to 2019 to 2023. This contrasts to the analysis OCA presented at the December board meeting. The types of errors hospitals are correcting include misallocation of revenues across payers, incorrect discharge counts, and off-hospital license revenues reported in the AFDR. These are exactly the kinds of issues that materially affect the metrics used to define high-cost hospitals. It is also important to note that the AFDRs were never previously used to define classifications like this, as board members have highlighted today. Hospitals submitted and certified them in good faith for financial reporting purposes, and it's entirely reasonable that certain errors only surface when used for regulatory purposes. Given that hospitals had no opportunity to review or validate their AFDR accuracy for prior years, years prior to OCA finalizing the hospital sector definition and high-cost hospital methodology, both finalized in 2025, we urge OCA to revisit the high-cost hospital determinations and associated target adjustment and account for prior years' resubmitted data. Going forward, OCA should set clear rules and clear deadlines for when data are locked down and when there are deadlines for correcting errors for both the spending target enforcement and for high-cost hospital determinations. Using known incorrect data when validated corrections exist undermines both fairness and credibility in OCA's enforcement process. Thank you.
Thank you. Looking virtually, seeing no hands raised, seeing no one at the podium, that concludes public comment on this item. Oh, excuse me, I'm sorry. You snuck up, you snuck down the side, please.
No, it is. All right. I'm not Steve online that's trying to get through, by the way. That's not me. Members of the board saying we didn't mean the data we sent now is dubious at best. But certifying data, what does certification mean? Clearly, the consequences for not being accurate or truthful in your data and certifying it must not be high enough. The fine, anything criminal, civil, I don't know. But if they're signing off that it's certified data, but we didn't mean it, what does that mean? I know what it means to me. When a teacher applies for a job and they disclose their history, they have to by law, and they have to also sign that what they've submitted is accurate and truthful. Because if it's discovered they weren't, they are dismissed for cause immediately. That's the world I live in when we certify something. Usually under penalty of perjury. I don't know what that is in your world, but it must mean something. And if it doesn't mean much, perhaps there ought to be a law to change that. When one of these hospitals has a $1 billion+ reserve built on the backs of the community that's struggling to get by in Monterey County, don't let them off the hook. They need to be accountable for what they've done and what they've submitted. Let's proceed. Do not let them delay by saying we didn't mean it. We'd like another crack at the data submission. That's not the world I operate in, nor should the state of California. Thank you.
Thank you. Seeing no hands raised virtually, and this time seeing no one at the podium. That concludes comment on this item.
Okay, and thank you again for all those who are participating in your public comment on that item. We are going to break for lunch. We will return at 1 p.m. Thank you. Welcome back and good afternoon. We will reconvene the OCA board meeting, and if we can call the roll, please.
Thank you. Good afternoon. Dr. Sandra Hernandez.
Present.
Secretary Kim Johnson.
Here.
Richard Kroenig.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell. Here. Dr. Richard Pan.
Here.
Don Molds. 6 present, 1 absent.
Thank you very much. We will move on to item 5C. This is an update on the total healthcare expenditures data submission regulations. Deputy Director, turn it over to you.
Thank you, Chair Johnson. So now I'll share some updates on total healthcare expenditures data submission regulations, also known as DSG 3.0. Next slide. Draft updates to the regulations and the data submission guide 3.0 were released for public comment on January 5th. Comments are due to OCA's email inbox at oca@hcai.ca.gov by January 30th of 2026, which is this Friday. We anticipate submission to the Office of Administrative Law by April, and you can and the public, the board and the public can review drafts of the data submission guide and the associated regulations on the HCI website at the link on the slide. So now we have a timeline for data collection. In January, OCA published a draft of the revised regulations, had discussions with the advisory committee and with the board today. In March, the board will review public comment, and in March or April, the regulations will be submitted to OAL. We hope to have the regulations effective in April, and in May, we'll begin the process for submitters to register with OCA. Next slide. So that wraps up my quick update on this, and I'll turn it over to the chair in case there's any questions.
Okay, that was straightforward. Questions or comments from the board? Okay, we will open it up for public comment.
We'll now take public comment on this item. Please step to the podium. If you're online, please raise your hand. Please limit your comments to this agenda item in 2 minutes if possible. Looking to the podium. Go ahead.
Good afternoon, Victoria Valencia from the California Hospital Association. We appreciate the clarity around the review process and upcoming milestones for updating the total healthcare expenditures data submission guide. CHA will be submitting a formal comment letter on the draft guide, and we'd like to highlight 3 key themes from that letter. First, we'll raise unresolved comparability risks with payer-provided provider attribution methodology and the need for establishing a standardized attribution methodology and establishment of a validation approach. Second, we ask for reasoning around the inclusion and exclusion of Medi-Cal supplemental payments given their scale and the risk of distorting year-over-year spending trends. Third, we flag issues with the integration of OCA's definition of behavioral health spending, including the risk of undercounting care that is delivered in settings where behavioral health is a secondary diagnosis on a claim. We appreciate the opportunity to provide input, and we look forward to the board's discussion and consideration of these comments at the March meeting. Thank you.
Thank you. Looking virtually, seeing no hands, seeing no one at the podium, that concludes public comment on this item.
Thank you very much, and we'll stay tuned for updates on this front. We will move on to item 5D. Yes, thank you. Exploring drivers of healthcare spending across commercial payers, and we'll welcome Research and Analysis Group Manager Andrew Fair.
Thanks. So in the next set of slides, I'll discuss OCA's work to analyze several drivers of healthcare spending across commercial payers in California. But before I jump into the content, I do just want to thank Mike Valley and his team here at HCI for granting OCA access to the HPD to enable the types of cost driver analyses I'll be sharing today. And also want to thank the health plans who submit data to HCI, which allows us to develop a better understanding of the healthcare landscape here in California. Next slide. So I'll just provide a little bit of context here. So OCA is statutorily required to analyze drivers of healthcare spending, and there's explicit reference to using the HPD in OCA's enabling statute. So in early 2025, OCA submitted a business use case proposal to the Office of Information Services here at HCI to begin using the HPD for that use case, and was granted approval. At the April 2025 HPD Advisory Committee meeting, OCA shared that it planned to explore how different factors, so things like aging, chronic condition prevalence, and utilization, might affect spending growth, both overall and at the payer level. In June 2025, OCA published its baseline report on healthcare spending for calendar years 2022 and 2023. At the October 2025 HPD Advisory Committee meeting, OCA presented a version of the forthcoming slides that masked health plan names. And then in the subsequent 2 months of 2025, OCA shared identified summary statistics with each commercial health plan and met with those who requested a meeting. So in total, we met with 4 commercial plans and obtained some of their feedback that we were able to integrate in the eventual issue brief that Vishal mentioned earlier this morning. Next slide. So at a prior presentation of this analysis, we were encouraged to remind folks of the differences between the OCA and HPD data sources, obviously recognizing that not everybody lives and breathes the data submission guide the way we do. And so this slide seeks to do just that. So the purpose of the OCA data is quite specific in that it reports on spending growth at different levels of granularity. So it could be at the regional level in one file, it could be at the market level or by age and gender in certain circumstances. But they're very targeted use cases for each specific file, whereas the HPD gives analysts quite a bit more flexibility to examine cost trends and cost drivers in a database environment. The OCA data is collected at a more aggregated level, whereas the HPD data includes claim line level as well as member level detail. The OCA data is generally extracted from financial accounting systems, whereas the HPD data is extracted from claims and encounter systems. And then last, OCA collects data once a year in the fall, and it collects 2 calendar years with each batch, whereas the HPD collects data on a rolling monthly basis. Next slide. So we're not fans of mystery novels here, so this is kind of the one-slide summary of the analysis. And so as you all remember, back in June, in OCA's baseline report, we documented that in the commercial market, total medical expense per member per year, TME PMPY for short, increased by 5% from 2022 to 2023. And TME includes claims, non-claims, as well as member cost-sharing obligations. And so the goal for this particular analysis was to use the HPD data from 2022 and 2023 to examine commercial payer level variation in the average age of members, the share of members who used healthcare services, and the share of members with chronic conditions. So again, circling back to the relative detail in the OCA data relative to the HPD, we don't have any visibility into things like utilization or chronic condition or acuity within the OCA data, but that's certainly available within the HPD. And so the findings here then from 2022 to 2023 were that we didn't find any meaningful change in the average age of members. We did find that the utilization rate decreased across all payers, and that chronic condition prevalence decreased for 4 out of 13 commercial payers. So the implications from the issue brief's conclusion are that since utilization decreased across all commercial payers, the observed increase in total medical expense per member per year from OCA's data collection is likely driven by other factors, such as higher prices or the greater intensity of utilization, which we intend to explore in future analyses. Next slide. So this is a bit of a stylized overview of the empirical approach the team used, but hopefully it gives some flavor for how it is we embarked on this analysis. So we use the HPD data to create a collapsed view at the member payer year level for 2022 and 2023 to align with OCA's baseline report. There is some data cleansing that had to occur, so we excluded about 0.5% of distinct members from the HPD analysis due to conflicting or incomplete age and gender information. So if somebody's age jumped more than 1 year from 1 year to the next, that's generally not how time works, so we knew that wouldn't necessarily be a valid record. And then from the OCA data, there's about 0.1% of member months or member equivalents that have an unknown gender. And so for the purposes of trying to compare the concordance across the HPD and OCA data sources, we excluded those respective records. But based on those exclusions, we were quite encouraged to see that approximately 85% of the OCA member months are represented in the HPD. The departures were most notable for plans that have large ASO lives. And so the count of member months in the OCA data was generally higher for some of that private self-insured enrollment. Next slide. So this will just describe the key metrics we used in the analysis. So I'll start with age here. So the eligibility table within the HPD reports an individual's age on a member month basis. So for this analysis, we converted age to a single value per member per year. And when somebody increased by 1 increment from 1 year to the next, we would just assign them the midpoint. So the example here is if you go from 35 to 36, we would give you the average age of 35 and a half for that respective year. As far as the utilization rates, so this is pretty simple. Just looked at the proportion of members who had at least one medical claim or encounter within a given year and divided by the total number of members with coverage in the eligibility table during that year. And similarly, for the chronic condition rate, looked at the proportion of members who had at least one service incident in the medical table within a calendar year containing a chronic condition diagnosis code divided by the number of members with coverage in the eligibility table in that year. And just a note, circling back to the granularity of the data set we developed, for those utilization and chronic condition measures, if an individual changed coverage during the year, so during an SEP, for example, and here's very fancy names, Plan 1 and Plan 2, suppose they only used coverage or accessed care with Plan 1, we would only count that individual as having utilization with Plan 1, but not Plan 2. So we do really want to zero in on the utilization and the chronic conditions that were unearthed under a particular enrollment with a particular insurer. Next slide. So just briefly touching on some of the limitations of our analysis, as this is our first foray into HPD. So the utilization and chronic condition measures are based on medical service records only. So we haven't fully delved into the pharmacy tables and the pharmacy claims as yet. As a result, we could anticipate potential understatements of the utilization rates in the analysis you'll see in the forthcoming slides. In addition, our analysis focused only on how many members use their health insurance coverage, so what economists lovingly call the extensive margin of utilization, but not how much care a member may have used, so that intensive margin of coverage or utilization. And in future analyses, as Vishal noted earlier in the meeting, we intend to explore that intensity of utilization in later analyses. And then we also focused on the commercial market, but do intend to incorporate Medicare Advantage analyses in future briefs. And then finally, we focused on three commonly cited drivers of healthcare spending: age, utilization, and chronic conditions, but recognize that that is far from an exhaustive set of explanations. Next slide. Okay, so being that the HPD was a new data asset for our team, we didn't simply want to just jump headfirst into the deep end without first assessing the extent to which it aligned rather closely with the data that OCA collected. So what we did then, we basically collapsed the HPD data to reflect the same level of granularity in terms of age brackets and gender categories that the OCA data shares, and then overlaid those two data sets. And so what you can see here on the left is basically looking at the age distribution for those who are self-identified as female in the HPD and the claims data. And then on the right is the corresponding figure for those who identify as males. And across the 13 submitters, you see considerable amounts of overlap, with the exception of one health plan. But overall, we felt pretty confident that not only are we able to crosswalk OCA data submitters to the HPD, but the underlying data is quite similar across the two populations when we look at the age brackets and their gender. Next slide. So first metric we looked at then was average age. And so what we saw here is when we look from 2022 to 2023, the average age among commercial payers didn't meaningfully change. It went from 36.1 years on average to 36.2 years on average, though there is, as you look across the rows, some variation. So a couple of payers saw decreases in average age, where a couple saw marginal increases in age. But in the aggregate across the commercial payers, we didn't see a tremendous amount of change from one year to the next. And that's generally been consistent with some of the Cover California public reporting on the demographic composition at the payer level in the individual market. Next slide. For the next metric then, we looked at utilization rates, and we found on average, commercial payers saw a decrease in the share of members who used medical services from 22 to 23. So going from about 76.7% in 2022 to 72.6% in 2023, so a relative decrease of 5.3%. But you'll see that there is pretty substantial variation in utilization rates across commercial payers. So Kaiser, for example, had the highest share of members with utilization rates at 83% and 79% in 2022 and 2023, respectively, whereas Cigna had the lowest share of utilization rates, hovering around 40% to 37% in 22 and 23, respectively. And as part of a conversation we had at the HPD Advisory Committee meeting, there was a lot of interest in understanding what may have changed, for example, between 22 and 23. And so in exploratory analyses, we did find that there were pretty large decreases in preventative vaccinations and lab and pathology services from 22 to 23. And this was confirmed in conversations with some of the payers we met with in November and December, who noted they saw corresponding drop-offs in COVID testing and COVID vaccinations from those 2 years. So this again speaks to wanting to explore the relative intensity of utilization in future analyses. Next slide. So again, we really did want to tread cautiously, as this is that first analysis we're undertaking in the HPD. And so to assess the reasonableness of the utilization rate analyses we presented, we looked to Cover California, which has had a claims database up and running for a bit longer than HCI. And so they've also done payer level reporting on utilization rates. And here too, you can see from 22 to 23, they report a very similar 5 percentage point decrease in utilization rates from 88% down to 83%. Next slide. Okay, and then finally looking at chronic condition prevalence or chronic condition rates. And then again, this is going to be conditional upon having used care in that calendar year. We can go back one slide. Awesome, thanks. Okay, so on average, the share of members with a chronic condition diagnosis was 31.5% in 2022 and increased to 32.4% in 2023, so just under a 3% relative increase. Several payers saw an increase in the share of members with a chronic condition diagnosis. So for example, a little over 5% for Kaiser, about 4% for Aetna, and about 3.5% for Sharp, while other payers saw a decrease in the proportion of members that had a chronic condition diagnosis. But we did see a handful of payers with rather large decreases in the share of members with a chronic condition diagnosis. So Valley Health Plan, for example, saw a 24% relative decrease, LA Care about a 16% relative decrease, and then Molina about an 8% relative decrease. Next slide. So here we're just going to seek to overlay several of those metrics. So the TME spending metric is denoted by the blue diamonds. The change in chronic condition prevalence from 22 to 23 would be the green triangle, and then finally the utilization rate change would be the red circle. And so you can see pretty consistently TME growth is to the right of 0. So TME increased across nearly every payer from 22 to 23. The red dots denote, as previously shown on slides, that utilization decreased across the board. And then those green triangles of chronic condition prevalence are kind of mixed between the left and the right sides of the 0 vertical line. And so this, I think, is just a helpful visual for us to keep in mind that all these trends might, even though we see cost growth increasing, it merits a lot more investigation that the OCA data can speak to only at a more aggregated level, but the HPD can really sort of round out our understanding of what might be going on at the sort of not missing the forest for the trees, so to speak. Next slide. So to summarize then, in this analysis, OCA used HPD data to build upon findings from its baseline report that featured aggregate total medical expense, or TME data. The OCA baseline report documented that TME per member per year increased by 5% in the commercial market, though there was pretty considerable variation ranging from about 0% growth to as high as just under 20% growth. And then we explored 3 potential factors that may contribute to spending growth and found there was no meaningful change in the average age of members. The share of members utilizing medical services decreased by about 5% on average, and the share of members with a chronic condition diagnosis increased by about 3% on average. Though, again, as you saw on the prior slide, there's quite a bit of variation across those metrics across payers. And so OCA will continue to use the HPD for cost driver analyses in the months ahead, building upon its statutorily required reports. And in future analyses, we'll aim to explore price variation in shoppable services and intensity of utilization. And with that, I'll turn it back over to the chair for discussion from the board.
Thank you very much. Very interesting data. Questions and comments from the board?
Thank you, Andrew. A really good kind of start for the first foray into the HPD data, and very, very useful. A semantic comment again, and I know you mentioned this in the presentation about the difference between the extensive margin and the intensive margin, but I think a bunch of both in the executive summary and this summary slide, to call what you've measured utilization is pretty different from the more common use of the word, which would be, I think, around kind of number of hospital visits or number of physician visits. And I would suggest a different framing or a different language as you're kind of summarizing this and making clear what you're measuring is the fraction of people who are using any service as opposed to kind of utilization more generally. And then relevant to our earlier discussion about errors in data, you know, the slide that showed the change in the fraction of people utilizing services showed really large declines for Valley Health Plan, I think LA Care, and to some extent Molina. And those declines are, you know, strongly suggestive to me of data problems or maybe a very big change in the composition of who's enrolled. But, you know, that it's hard to imagine the real world changed that much. And then if we go, I think 2 slides later to the chronic condition slide, you know, you see again, LA Care and Valley, you know, really big declines and a little less markedly Molina as well. This is suggestive to me that there's kind of something wrong. And I know that you're not the custodian of the data, and the HPD folks are probably looking into this. But again, as you present, might be useful to alert users to, you know, don't take all this at face value kind of thing.
Yeah, and I think that was the sort of impetus behind meeting with, or at least sharing previews of the summary statistics and offering to meet to learn more to the extent payers were inclined to. And so, yeah, I think in the course of some of those conversations, the payers did share that they're undergoing data warehouse sort of transformations that could account for some of these data anomalies. And so it's on Mike's team's radar. And so, yeah, I think they're continuing to work towards better and better data quality with each passing submission.
Thank you. The other thing that was quite suspicious on the utilization slide, and you pointed out that I think Cigna had, you know, much lower. Like, really? I mean, again, I'd be interested in what's going on the data side there.
Yeah, Andrew, with that caveat about the quality of the data, and also this is, you know, still in the transition, the normalization post-COVID. And I understand this might be an unfair question for you since this is our first stab at this analysis, but it felt counterintuitive to me to see increases in chronic conditions, especially in larger health plans. Even in light of reduced usage of services or whatever phraseology we'll use. And some of these very big health plans had, you know, substantial changes in chronic condition frequency. I'm just curious, like, do you have a sense of, was that within your expected range of variation for big populations like that? Because that surprised me a little.
I think this is sort of a V2 where we took a coarser sort of first pass where we just have the chronic condition warehouse, 30 or so flags for chronic conditions. We didn't do sort of exhaustive explorations. Is it asthma? Like, so where's the heterogeneity across chronic conditions? Are certain plans picking up a particularly more acute population? So I think in the second iteration where we take on, we begin to explore utilization intensities, trying to dig into sort of the number of chronic conditions, comorbidities, and sort of, are there certain sorts of selection effects to certain plans that are attracting these kinds of enrollees based on plan, either product type or sort of other characteristics. So we didn't quite explore that level of detail in this foray, but that's on the roadmap.
No, I really appreciate the presentation. I know that in your limitations section that that you are going to be delving into some additional data, for example, like chronic conditions. You know, you may have someone who has asthma who didn't have a visit. Now, technically, they probably should have one, but depending on maybe it's mild and if it's well controlled, they may not actually, you might not see a visit, but they'd be on, let's say, a controller medication or something. So I think it's a great first stab. But do you want to speak maybe a little bit to the timeline into, for example, maybe looking at those pharmacy claims or other types of things that you've described in your limitation that you said that you're going to be looking, for example, the intensive margin as well. I think, people with chronic conditions, it's not just, it's also how well managed they are will drive costs and so forth. So do you want to maybe speak to not just the limitation, but when, as you said, future analyses we tend to explore. So what do you think is the timeline for those future analyses?
Yeah, great question. So first, let me circle back to sort of your initial observation around chronic condition diagnoses. So there is a set of flags within the HPD that have a look-back period. So it could be anywhere from a year to 2 years. I think for our purposes, to your point, somebody could have been diagnosed with cancer and it's 2 years ago and it's in remission. So we wouldn't necessarily expect that to be driving commercial costs 2 years later. And so that's why we really wanted to tie these diagnoses to the utilization within the particular calendar year and the plan in which they were enrolled. But there in the appendix of the issue brief, we do show that alternative operationalization that has that kind of retrospective look back of chronic condition prevalence. To your other question, I think the slide at the beginning of today's meeting sketched out sort of a rough timeline. Somewhere around Q2 and Q4 is when we're hoping to have those analyses available. I will say there is a little bit of a range because we do want to make sure we have a chance to meet with plans, solicit their feedback, incorporate their feedback, also work on the QA with our colleagues in OIS. So we could finish on it. I mean, this particular analysis, for example, was finished, I think, in September, and about a 4-month runway for going through the review process and making sure we're in touch with stakeholders. So the aim would be to have those 2 additional analyses available sometime during this calendar year.
Okay, great. With those additional data. Okay, now it'd be interesting to see what the contrast is, but I appreciate this presentation. Thank you.
Yeah, thank you, Andrew. I appreciate your foray into this space. I'm sort of curious how you're thinking about Medicare Advantage per se. That is an area also that, and I'm not sure we saw that in the timeline, and what are some of the unique challenges. And then I'd love to just know, just top line, are there themes coming out of your conversations with the plans that have influenced your thinking on the data?
So on the MA front, the first iteration of this did include MA. I think to Rick's point, there were a couple of data quality issues that gave us cold feet. And so that's kind of where we left it for now. We're hoping either there's a version where we omit certain plans because of data quality, or that data quality enhancement gets matriculated through in a subsequent iteration of a quarterly build extract in the HPD, such that we can integrate MA. But we wouldn't want to put out, for example, a 0% utilization rate. We know that sort of intuitively doesn't make sense. And so we want to make sure we can sort of either have those conversations with the plan or find other areas in which we could present on other market categories beyond the commercial market. And then in of course the conversations with health plans, I think they were incredibly fruitful, soliciting feedback. So I think we're presenting here sort of parent level entities, right? So the overarching umbrella organization, but there's a lot of devils in the details on the submitter level detail that goes to the HPD. And so we got great feedback on whether or not a particular submitter should or shouldn't be included as part of their umbrella organization. Lots of great feedback on directions they'd like to see our analyses move with sort of a regional focus, so that some of these plans can get a sense of how their performance is relative to some of their peers that also offer products in their area. Lots of, I think Rick hinted at this, and it's sort of on our radar as well. There's lots of ways to operationalize utilization or chronic condition prevalence, or pricing or intensity. And so I think we got a lot of food for thought in the course of those conversations that we're taking back to the drawing board and seeing what can be implemented as we sort of go from our crawl, walk, run approach to working in the HPD.
Are we trying to eventually talk with all the plans?
All in terms of not just commercial plans, but
no, the commercial plans.
Yes.
That is a goal.
So we offered to meet with whoever was interested. I think
good uptake.
A third of them took us up on it and provided great feedback. I'm sure others that I would also note in the plan's defense, there's previews for the OCA TME data, for the APM and primary care data, and then we also hit them with an HPD request. So want to recognize that we don't want to tax their bandwidth with just continually soliciting their feedback. So it's not to say that they weren't interested and engaged, but at a certain point during the holidays, I think folks need to get some time away from OCA.
Or the gift.
Thanks. To Ian's earlier point, part of what may be going on is just more coding. I mean, in general, there's kind of more coding as there's more risk-adjusted payment stuff, and so it may not be a real change in chronic condition prevalence, but more complete reporting of it. Question, Andrew. I know we heard some of this when Michael Valley came and told us about the HPD, but my memory is not so good. To what extent will future reporting, future work that you're doing, be able to report directly on changes in price?
So I think just to preview, sorry, got a little bit too close to the mic there. Just to preview, so the way we're thinking about price variation is looking at the list of CMS shoppable services. So digging into sort of what are the prices of things like a lower limb MRI or a lab test, and how do those vary both within and across regions. So that's definitely on the roadmap. It's kind of limited in scope to those shoppable services where CMS generally thinks that those shouldn't vary in quality, but we wouldn't look at sort of an overarching price index along the lines of, say, HCCI, for example, or the RAND price transparency data kind of does a catch-all of price at a hospital level or other levels of granularity.
And why not?
I think it's taking sort of a crawl, walk, run approach is sort of our motto here at OCA. And so to keep a tractable issue brief, I think we'd want to sort of start with something that we think we can accomplish in a reasonable amount of time and not maybe bite off more than we can chew. But it's sort of I think plenty of bites of the apple to be had. And so that's just on the roadmap for 2026. But we're always open to feedback from you and others on what should be on our analytic roadmap and plan for reporting out of the HPD in years ahead.
We'd be happy to provide some suggestions.
Yeah, Rick, as you'll recall, we put out that crosswalk, the facility crosswalk to NBI. So that's out for public comment in terms of making revisions or corrections to that. So that could be the basis for looking at hospital prices, for example, in the future.
Thank you. I think my question is probably redundant or at least answered, but I'm just curious why you wouldn't use the TIC data, because they have new rules out, as you probably know, and there's just increasing granularity on hospital pricing and negotiated rates that I think are just really helpful supplements to claims. And it may just be what you just said, like a bandwidth issue, but there's increasingly useful and actionable data from those sources.
Yeah, I think we got this question quite recently as well from another stakeholder, and so I don't think we're opposed to drawing upon whatever data assets are available. It just I think the team is eager to get its hands on the HPD data, and sort of once that authorization came through a couple months ago, we wanted to make the most of it. But that's not to say we wouldn't branch out and look at other non-HCI data sources in the future.
I can't help myself on the question of prices, but just for your consideration, I mean, at least on the commercial end, from plans, we very routinely, with every renewal, get the list of most top DRGs and the prices and volume associated with those. So I don't know how much extra work that is, but to look at what are the most common / most expensive DRGs across the state and creating an index of those prices might be something to look at.
Okay, so appreciate that where we are, and then it sounds like we've got a good amount of input on future looks at this, so appreciate that discussion. We will open it up for public comment.
We'll now take public comment on this item. Please step to the podium. Looking virtually, seeing a hand raised. Steve Shortell, we'll start with you. You should be unmuted on our end right now. Go ahead.
Okay, can you hear me now?
We can. Thank you.
Okay, I apologize for not getting through earlier. The problem, pretty sure was on my end. I'm on a relatively new laptop and had to configure the microphone. So in any event, so a great, initial foray into the data. Just a couple suggestions which may already be on your work plan going forward. Around chronic conditions, it would really be useful to look at those with 3+. These are the sick patients. As the data show, there's a third, a lot of people have at least one chronic condition. But it'd be interesting to know those that have, say, 3+. That's sometimes used in risk adjustments and various analyses would be one thing. And then also, I think it was hinted at by one of the board members to also look if there's a comorbid condition that's mental health, which would also give some insight into, primary care and things of that sort. Many people with chronic conditions also are depressed, for example, clinically diagnosed depressed, if they have diabetes, etc. So that would be one suggestion. The second suggestion is if you can look at low value care broken out by plan. And those have been established now. As you may know, this guy, Mark Frederick at Michigan and Mike Chernow have been working on that. And there's about 7 or 10 pretty well established low value care diagnoses procedures. It's low hanging fruit in a way to reduce costs and improve quality at the same time. So that might be worth looking at as well. Thank you.
Thank you. Looking to the podium. Go ahead.
Beth Capel for Health Access. We appreciated this report on commercial payers and we'll look forward to further iterations. We particularly appreciated naming names so we know which health plans we're dealing with because we do think there will be differences among them on some of these factors. We would note, in addition to the discussion the board already had about data quality, that we were struck that the smaller plans seem to have more volatile data than the larger ones, which does raise, whether it's data quality or just changes in membership, there, things to look at. The list of shoppable services is a remarkably limited list and actually doesn't do much, I think, to move overall costs. At least that's generally our observation. So I think as we look at various other data sources, whether it's HCCI or others, we would be excited to see a much more extensive list of actual prices. And this is one of the things that we made sure that the HPD would be able to give us. So it is an important part of our building out the data infrastructure. Thank you.
Thank you. Looking virtually. Ivana, I see your hand raised. Go ahead.
All right. Can you hear me?
We can.
Hi, this is Ivana Krajcinovic with Unite Here Health. I wanted to share some data that we recently put together on the use of our members' use of primary and urgent care in Monterey County to help add to kind of the discussion. And I've submitted a letter that you'll see next month that includes this information in it. We were interested in, we all know about the dominance of the hospital systems in that area, and we've noticed that they've been buying up practices. So we wanted to take a look at our data and see what impact has that had, because if you look at like primary care and urgent care is very well developed in Monterey County, so a lot of people use it. Those are kind of the entry points into the healthcare system. And how many of those practices are connected to one of the big 3 hospitals in the area? And we were really stunned to find out that 77% of our members' primary and urgent care visits and 84% of the total spending for this care go to providers that are connected to the hospital systems. And it basically means that 8 out of 10 people are going to entering the system in a way that's going to make sure that they end up in one of those expensive hospitals. We actually tried to, in an effort to keep people out of the hospital, we came up with a new benefit this year to really have free primary care, and we wanted to look at some primary care practices in the area that could take our members that, more than sort of individual practitioners and that were accepting new patients. And we found a group, the Santa Lucia Medical Group, that could do that. And we've had a partnership with them, and we actually pay them a little bit more. I mean, the other striking thing about this data is how little the independent practices are paid, and the hospital affiliated practices, I should have noted, are paid a lot more. But we couldn't, and that practice is in Salinas. We could not find a single practice, independent practice of size on the Monterey Peninsula proper, where most of our members live, that we could partner with. So just thought it was important to think about how the reach of those hospitals extends even into the entry points into the system, and that's worth considering as well. Thank you.
Thank you. Looking back to the room, seeing no one at the podium and seeing no other hands raised, that concludes public comment on this item.
Thank you very much. And again, appreciate the work on that. And as the director said, a group very interested in the data. So thank you for the work there. We will move to our final informational item of the day. This is the Spending Target Enforcement Performance Improvement Plan follow-up. Assistant Deputy Director and Deputy Director.
Thank you, Chair Johnson. Now I'll cover some follow-up items from last month's board meeting discussion of performance improvement plans. Next slide. I'll begin by reviewing what we have discussed with the board today on spending target enforcement. As a reminder, OCA is collecting initial feedback from the board, the advisory committee, and the public to inform the development of spending target enforcement regulations in late 2026. Further opportunities for feedback will occur with the presentation of draft regulations, including a public workshop. So far, OCA has discussed assessing performance, enforcement considerations, technical assistance, public testimony, and performance improvement plans. Next slide. This slide was presented at the July 2025 board meeting. It shows the initial plan for discussions on various enforcement topics ahead of the regulations process later this year. And I'll take us to the updated timeline to reflect what actually happened in 2025 and what we have planned for the remainder of the year. So we're gathering feedback between July of last year and then through June of 2026. A discussion of spending target penalties is scheduled for spring 2026, and that will result in a board vote on the scope and range of spending target penalties. And I want to provide some clarity on this. The role of the board here is to approve the overall scope and range of spending target penalties. The board will not do this every time a penalty is assessed, but may provide input on individual penalties during closed sessions. OCA's role is to enforce the spending targets, which may include assessing penalties. We will spend more time on roles later this spring when we begin discussions with the board on spending target penalties. And lastly, OCA will develop regulations from summer through October 2026. Next slide. So now I'll turn to a few follow-up questions from the last board meeting. What we have listed here was a question we spent a lot of time on in the last meeting. The question is, do entities have to go through a PIP before being assessed a penalty? So here we've included a few areas of the statute. The first notes the intent of the statute is that enforcement be progressive and that entities are assisted with coming into compliance via PIPs. Next, we have the director shall allow entities opportunities for remediation. And lastly, on this slide, we have a limited set of situations where the director may directly assess penalties, including when an entity repeatedly neglects to file or implement a PIP. Next slide. For these reasons, yes, OCA will first require a PIP before assessing a penalty. Per the statute's legislative intent that enforcement be progressive and that entities be assisted with coming into compliance via technical assistance and PIPs before being assessed a penalty. We also want to note that additionally PIPs identify root causes of unaffordability by working with entities to make real lasting improvements, create better understanding of how healthcare entities operate and can identify meaningful interventions that may support other entities' performance improvement plans, as well as future state policy direction. Next slide. So next we have a question about Oregon's cost target penalty. The Oregon Health Authority, or OHA, has a financial penalty for exceeding a cost target that is based on a percentage of excess spending that increases annually for repeated offenses. We'll provide more information about their penalty structure in a later presentation on spending target penalties. And then, as a reminder, the timeline slide from a few slides ago, we hope to have these discussions between April to June. The next question is, does OCA have the resources to require and monitor PIPs for potentially hundreds of entities? So we are considering what resources we are required for the PIP process. I do want to note that we are staffed for enforcement, as that was part of our original funding. Ultimately, who proceeds to a PIP will depend on OCA resources and the performance of healthcare entities year to year. Next slide. So there was another question about whether entities in other states have shown meaningful change due to a performance improvement plan. Massachusetts deemed Mass General Brigham's PIP successful with a goal of 176.7 million versus 197.1 million in achieved savings in 18 months. 70% of savings came from price reductions. MGB strategies included price reductions, reducing outpatient rates at multiple facilities, reducing rates to state-based marketplace coverage, and other insurance discounts for a total of 142.9 million in achieved savings. They also, the other two non-price related strategies were reducing utilization through an integrated care management program, reducing skilled nursing facility utilization. MGB has a health plan utilization management program, and focusing on reducing utilization for MRIs and CT scans, which collectively resulted in 48.1 million in achieved savings. And they also shifted care to lower cost sites, such as hospital at home or virtual care, which achieved 6.31 million in achieved savings. We have received public comment that MGB, Mass General Brigham, experienced a budget shortfall shortly after that we've reached out to the Massachusetts Health Policy Commission. They said that it was not due to the performance improvement plan. The Mass General Brigham was doing some restructuring in terms of reducing their administrative and managerial positions with minimal impact to their clinical staff. And these savings were achieved before they did that restructuring. And then on the next slide, actually, I didn't cover the last point on the prior slide. Oregon also has a performance improvement plan authority, but they have not yet required one. And then taking us to the next slide, we also had a question about whether OCA would need to accept a greater role in telling entities what to include or focus on in their PIP. So our response to this is only to the extent consistent with law. We do have responsibilities to ensure that entities come into compliance with the targets and that PIP goals and strategies do not erode access, quality, equity, or workforce stability. And then we have some language from the statute noting that the director shall ensure PIPs do not erode access, quality, equity, or workforce stability. Next slide. So this is the last follow-up item. And the question was about whether PIPs allow entities to get out of complying with the spending target while they are implementing a PIP. So our response to this is no. When an entity misses a spending target while implementing a PIP, the statute provides OCA with options to enforce the target, such as requiring modifications to the existing PIP, requiring a new PIP, or assessing penalties. And then we have the statutory language for these options listed here. With that, I'll turn it back over to the chair for board discussion.
Thank you for the follow-up on those items, and just noting that you identified spring is when this will come back to the board. So I know we also used, I think you used, I love visuals, a flow chart in the prior presentations too. So maybe there's a way to incorporate some of what you have as a follow-up in that when we see it next. Richard, please.
Thank you for that presentation. I guess a couple of questions or items. So one, in terms of Oregon, as you may note, that Oregon has not imposed a PIP, and you'd have the section as well as Oregon's cost target penalty. While that may be in statute or regulations on Florida, have they ever actually exercised it, or is this simply a I say theoretical? But I mean, no, it's one thing you have a flow chart or whatever. This is what we're going to do, but if they've never actually implemented it, we don't know what the consequences of that were. So I guess that's the question. Have they actually ever imposed a cost target penalty on anyone yet?
They have not.
Okay. All right.
You're just ahead of us in terms of timing.
Sure. Right.
Yeah.
And do we know of any entity that's done that yet? Imposed a penalty on someone who missed the cost target?
Oregon and California are the only states that have financial penalty authority.
Right.
So yeah, we're kind of.
So just recognizing we're in new territory here. Okay. And then the other item, actually, what you just presented, and again, just reading the statute, and I think I had a hand in writing some of that. What it does say is that if the director determines that is not compliant with an approved PIP and does not meet the cost target, may assess an administrative penalty, but that the office shall not be assessed. That an entity that's fully complied with an approved PIP by the deadline established by the office shall not be assessed an administrative penalty. So I just want to be sure. So that I assume that means that if they complied with the PIP that we approved, they would not be administered an administrative penalty. They'd have to both violate the cost target and not be compliant with the PIP. Correct?
Yeah, that's correct.
Okay. All right. I mean, I think if we told someone you need to do this because you didn't, and then they followed along and we didn't get the results we wanted, we could amend the PIP, or we could go back and tell them maybe that didn't quite work, but I don't think we can just go and say, well, you did what we asked you to do, but we're still going to hit you with a penalty. Correct.
So you're correct. The statute does say that. So they could be on a PIP that we approved and they could comply with the PIP but still not meet the spending target. So we could not assess a penalty in that circumstance. But we could say you need a revised PIP because you're still not there, because our statutory duty is to help them come into compliance with the spending target.
Right. Yeah. I mean, and let's put it this way. That makes sense to me in the sense that if we said, please change the way you behave in this way, they did change, and we still didn't get the result we wanted. I wouldn't say whose fault is it, but yeah, we could say, hey, maybe this doesn't work. We got to do something more, right? Okay. I just wanted to clarify. That's what the statute said.
I think that exchange just underscored my real concern with this. Like, technical assistance and enforcement and accountability are so fundamentally different. And I mean, to Dr. Pan's point, does it mean that that OCA staff did the wrong recommendations in a PIP? Because I just feel like this could continue to push out accountability indefinitely. And I appreciate the clarification of the timeline up there, but I mean, it just sounds like there's exceptions where like at some point we just have to say this is the target and you made it or you didn't.
We hear you, and the statute, has certain constraints that we have to follow. So we do have to go through those steps.
And is it possible, though, I mean, maybe this is as clear as we can get, that what is allowable? I mean, in terms of enforcement while a PIP is in place?
Right. So yes, the language is clear that that if an entity meets the PIP, that at least for that year, we don't have the option of, we don't have the authority to levy a penalty. Did you want to add anything?
We can modify the PIP, but this is how we will be learning. Obviously, it's an iterative process, and we will be learning as we assess performance on the spending target. The statute does give us these circumstances, limited circumstances, where the director can go straight to penalties. So when we look at, if they complied, we have to determine, did they comply with the PIP that we approved, right? And when we look at that level of compliance, we're looking to make sure that they did so in good faith. No willful conduct that would make us go straight to penalties, because willful misconduct, misreporting information, that kind of thing, we could go straight to penalties. So there is some ability there, but the way the statute is drafted, again, if they meet the PIP that we approved but still miss the spending target, we cannot assess penalties for missing the spending target. Did you want to add anything, Vishal?
In addition to modification of the PIP, like there's always going to be a new year of data coming in every year. So, you could modify the existing one, or their performance will be assessed for the new year. So like they could get put on a PIP again. And then, if they repeatedly fail to implement a PIP, then that would trigger some of those, the direct, yeah.
I sort of wasn't at the meeting, so I really appreciated the clarification on those questions. I'm curious, in the example of Massachusetts and Mass General, I assume that was an example, that they had other examples where that is the only example. Interesting.
And just a comment, Sandra, on Mass General, I think, has annual revenues of in the $20 billion range. So that PIP was probably 1% reduction in spending. So not zero, but.
I think that I think this, first of all, of course, what we want to do is we're not going to penalize someone into compliance, right, alone, right? We need to, and I think the idea is that, again, if someone doesn't follow the PIP, they report inaccurate data, you can go straight to a penalty, right? But if someone's in operating good faith, trying to get their cost target down, working with the office, complying with the PIP, and if we have to modify it because we're still not there, because we're not going to be perfect either, but it does speak to, I mean, the PIP has a lot of weight, because if you don't compliant with the PIP, then you're open to penalties. So let's not underestimate the level of, I guess, authority or influence this office can have for any entity that doesn't meet its cost target, because literally their ability to not get enough penalties dependent on their compliance with that PIP. And obviously there's going to be a lot of people interested in seeing how much we're going to ask for in a PIP, right? And there's a certain level of transparency too, right? If we said, well, in order to get your costs down, we want you to lay off half of your workers, I think we'd want to know about that, right? Is that really the right solution, and so forth? So I'm not saying that that's what the staff would propose, but I think there were some also concerns that exactly what are we going to ask entities to do to get those cost targets down? Because as the statute said, it's getting the costs down, but you don't want to cut off people's quality, access to care, right? Like shut down the whole line of business, right? That could be a quick way to get your costs down, but maybe the community needs that service, right? So again, not expecting the office to necessarily do that, but ask that. But I mean, we want to be sure there's some transparency in what we're asking entities to do to reach that cost target. And we also don't want the entities themselves saying that, well, okay, the way we're going to avoid the administrative penalty is to do something that might be harmful to the community as well.
Thanks, Dr. Pan. I would add that for the, at least for specifically for the MGB PIP, it didn't require on layoffs. That wouldn't necessarily do anything to improve spending performance. Is the way that Massachusetts described it to us as well.
I just think we should be clear here that the goal isn't to get to penalty. Right. The goal is to get to spending down.
Exactly.
And so, so the robustness of the PIP is really where we're going to see the most, because even if we assess a penalty, they still haven't reduced spending to the target. And so I think the PIPs are going to need to be very robust in nature in order for the tool to be useful to what our real end goal is.
I don't disagree at all. Like, ideally, we wouldn't be in the PIP business because there are some very expensive consultants out there who do this. And having worked in a hospital system, I mean, it's a very sophisticated undertaking. So I just worry about our ability to provide optimal guidance when I think our effort should be focused more on just making targets.
I did not much think that OCA would be in the business of providing guidance, and to Richard, Dr. Pan's earlier comments about, which I think implied to me that OCA would be making suggestions about how entities would reduce their spending. I imagine this is mostly the other direction, that entities would come in and make statements about what they intended to do, and OCA staff would review that, and if the entity is proposing something that's going to be very likely to impede access or quality, OCA might say, no, this doesn't seem like a good idea. But the direction of this is coming from the entity, not from OCA. Is at least what I imagine.
That's correct. And we would, there's guardrails in the statute that we need to follow. So we would be reviewing and providing feedback. And we ultimately get to approve the PIP, and then the board also has a role to provide input.
Yeah, and just Sandra, reacting to your comment, I agree the goal is to get spending down, or at least per statute to grow less. But I live in the city of Alameda, where I know darned well if, they have a speed target of 25 miles an hour, and I know darn well if I hit 26, I'm out a couple $100. There are other municipalities that do not have such a strong enforcement regime, and I'm maybe less cautious than I should be, and I think those penalties really, really do matter.
Another robust discussion on this topic. Appreciate the work, that's continued work in between here that as we work to refine and land on this structure. We'll go ahead and open it up for public comment.
Thank you. We'll now open it to public comment. Please step to the podium. If you're online, please raise your hand. And noting that this is our last agenda item of the day, this will also serve as the general public comment period. Going to the podium, please go ahead.
Beth Capel for Health Access again. Several things which this conversation has clarified that we think future board materials might clarify. As Ms. Tatayan clarified, it is not correct that a PIP is always required before a penalty. There are, in fact, the list of instances where there can be a penalty, where you, as the language of this conversation has said, we can go direct to a penalty for things like failing to file a PIP, or repeatedly failing to implement the PIP, or knowingly failing to provide the information the office requested. I'm just reading from the law now, but I think we may need to label these things somewhat differently in order to clarify the conversation for all of us, including those who may be subject to penalties. And so We agree that before a penalty can be imposed for exceeding the spending target, that there would be a performance improvement plan for the reasons that this board has just been discussing, that the point is to get costs down and to encourage change in behavior. I agree with Board Member Cronick that it will be on the entity to propose how they are going to do that. But if they come in and say, we're going to close half our service lines, the law is intended to protect against that. The thing that has been absent in this discussion and that we spent a lot of time on in this month's letter and in somewhat less in some prior letters is the public process, because we think it's important that there be public process and public notice, that accountability at every stage along the way, from the moment when you set the target to the moment when the staff determines that a target's been exceeded and starts the 45-day process. All of that public transparency will help with accountability and will help with compliance. And so we have made concrete proposals about where at each stage things should be made public. The staff, of course, will need to look at that and see if it makes sense given their vision and their workflow and all that important work that they do. I only get to comment on. But that public, we are all of us in the midst of laying out the process for the next 10 or 20 years. And decisions, when we develop those comments about public process, we reflected on other enforcement processes that we have worked with over the 40 years of working with healthcare in this state, and where we would want things to be public and where we think the people who will be dealing with this 10 or 20 years from now would hope that they would be public. Thank you.
Thank you. Looking virtually, Steve Sartell, please go ahead.
Briefly to the MGB experience, I just want to underscore, it may be the fourth bullet there, what they did. Some of that was around low value care, again, linking to earlier comments, MRI, CT utilization, and so on. It's well established those are overused, often low back pain imaging and so forth. So just want to note that. A brief comment on the PIP. Yes, I understand. I think we all do. It's to be initiated by the hospital and what they're doing to meet the target, etc. It might be helpful in terms of giving guidance where it might be needed to create like just subheadings or subcategories. It might read something like, to the extent that this is relevant, please comment on the following if applicable. And one subheading might be efforts to move care to lower cost settings. Another subcategory might be eliminating low value care. And there could be other suggestions as well, as our knowledge of the spending drivers of this and the inefficiencies and some would say sludge in the system become better known. So those are just suggestions. It doesn't have to be heavy handed at all, just suggestions to help structure the reports and have hospitals give us the benefit of their thinking about some of these factors. Thank you.
Thank you. Back to the podium.
Good afternoon, Jenny Nguyen with the California Hospital Association. We appreciate the follow-up discussion on the PIP process. As OCA moves to finalize this component, we urge the board and staff to consider and incorporate the following aspects into the PIP process. First, OCA should assess entities on a multi-year basis in determining which entities enter the enforcement process and are subject to a PIP. Hospital spending growth, as measured by OCA's methodology, is highly volatile, swinging widely year over year. Without multi-year evaluation, hundreds of hospitals each year will find themselves subject to a PIP solely due to volatility in their measured spending growth, rather than underlying growth trends in excess of the spending target. As for PIP submission and implementation, we urge OCA to look to other states that give entities a longer time frame to submit a PIP, so entities can develop a comprehensive plan that meaningfully addresses their spending growth while fulfilling other requirements in statute, including protecting access, quality, and workforce stability. Adequate time for entities to implement and make progress is crucial, as well as giving entities the flexibility to carry out their individually tailored cost-saving strategies that they themselves identify as appropriate for their own organization. Lastly, OCA must protect confidential information and documents shared during implementation and assessment of the PIP. We look forward to learning more details about the PIP process, including rules for how OCA will identify entities that proceed to the PIP, as roughly over 600 entities in total will be subject to the enforcement of the spending target. Thank you.
Thank you. Looking virtually, Anna, you should be unmuted. RN, please go ahead. Anna, we can't hear you yet. You might need to unmute on your end also.
Oh, great. I think I found it. Thank you. Yes, wonderful. My name is Anna Malino. I work with the movement to end privatization of Medicare. And I'm really curious that in Massachusetts, I just a quick Google search showed that there are about 1,200 health facilities in the state. And that doesn't even include any of the payers. And I'm just curious that only one, Mass Brigham General, was exceeded the cost target. I find that kind of remarkable. So that's one. And then my second comment is that I do believe that Mass Brigham General did end up cutting their workforce. And while they might say that it had nothing to do with the PIP or coming into compliance, what it probably did is it did cut into their profits. And then, of course, once you cut into profits, the first thing that you want to do is to cut your workforce. So those are my two comments. Thank you.
Looking back to the room, seeing no one at the podium and seeing no hands raised virtually, we'll give it just a moment. That concludes public comment on both the previous agenda item and also our general public comment.
Maybe we have one more.
We will pause. It looks like we have another public comment.
Oh, it's okay for general public comment now? Yes? Okay. I'm Victoria Valencia from the California Hospital Association. I'd like to respond to an exchange from the beginning of the meeting today regarding OCA's analysis of the Monterey hospital market and the factual and contextual factors that were misconstrued, ignored, or simply made an error in this analysis. As we wrote in our December letter to the board, OCA dismissed cost shifting or even cross-subsidization without a proper analysis. First, it used incomplete data that underreported Monterey's hospital's public payer mix. Second, it didn't look at whether public payment levels are comparable for Monterey hospitals and the report's comparison group, which was the Bay Area. We showed that Monterey hospitals are paid roughly 25% less for Medicaid and Medicare patients than those Bay Area peers on a case mix and volume adjusted basis. When looked across all payers, Monterey hospital payments are basically the same as their Bay Area peers. A previous commenter question references on the existence of cost shifting. However, this argument is really muddied by semantics. What the data show is that cross-subsidization is undoubtedly a major feature that drives differences in commercial reimbursement, as well as apparent difference in in operating margins when viewed only on an individual hospital basis. Other comments made today simply distract from the heart of the matter. Assertions that hospital investments in community care sites function as a pathway to hospitalization mischaracterize their purpose. Urgent care serves primarily to divert patients from hospital settings. OCA does not need an expansion of its authority to account for additional background factors, including various forms of cross-subsidization when making decisions on sector or targets or target adjustments. We urge OCA to honestly engage with information put forward by regulated entities and stakeholders, including when that information challenges simple narratives of what drives healthcare spending. Thank you.
Thank you. Continuing general public comment. All right, that concludes public comment at this time.
Thank you very much. While we will not convene in February, we invite and encourage you to continue engaging on how to make more healthcare affordable and bring those great ideas and suggestions to us in March. We appreciate, again, all of the engagement from public and community. Thank you, fellow board members. And with that, the meeting is adjourned.